Hello?
Yes, Dr. Wheeler.
Right, hi, great.
Okay, so you could leave it installed and just mute it.
Yes, thank you.
Did you present? Like, what the policy? What did you guys What is it?
giving the time for some more people to come in. A couple of things were presenting from us. So let's just give 5 more minutes and then we begin. 5 more minutes. So we will start at 20 past 9. Thank you all for your patience. Again, I check, so not many. We're doing this video online. Thank you. Good morning, everyone. Thank you so much for being a part of today. I'd also like to say a special a special hello to our online audience. We are going to commence with the National Anthem of Children today. Would everyone please stand? Thank you. You may have your seats. So good morning, everyone. Welcome to day 2 of our inaugural conference from the Tobago Hematology Society for Blood Transfusion, Society for Hematology and Blood Transfusion. We are going to commence today with a welcome address from Dr. Kenneth Charles. Dr. Kenneth Charles is a senior lecturer in hematology at the University of the West Indies, an honorary consultant hematologist with the North Central Health Authority. He's a graduate of the University of the West Indies and a fellow of both the Royal College of Physicians, the Royal College of Pathologists, with a certificate of completion of specialist training in hematology. His main research interest is global hematology and the disparity between blood transfusion still within in developed and developing countries. He is founding chairman of the University of the West Indies Blood Donor Foundation. Dr. Charles has been appointed consultant director of the National Blood Transfusion Service by the Ministry of Health, with the responsibility of transitioning it to 100% voluntary, non-remunerated blood donation. He will now do the welcome address and update on the structure of the blood transfusion service of Trinidad and Tobago. Please welcome Dr. Kenneth Charles.
Good morning and thank you. Distinguished guests, all of you are our colleagues from abroad who share their experiences online. That's about how our transfusion services work elsewhere. Our medical students, I'm grateful to see you here to demonstrate what you have learned, what you presented, and what you now believe. Members of the fledgling Trinidad Tobago Society for Hematology and Blood Transfusion, exceedingly proud of you. I'm glad that you got off the ground by a show of unity and commitment to our common. Dr. Sergio Singh, I'm very pleased to have you here. Good direction and guidance, having achieved so much in the development especially very much as a show of unification of the hematology practitioner, especially because we both on the way out now, with men in unification. So I will share with you, having discussed the history of the blood transfusion service in Trinidad and Tobago yesterday, some things that have been done by various organizations, most importantly the Ministry of Health, and underpinning at the University of the West Indies and its students in planning the way forward to take more blood transfusion service from what has been described to where it needs to be, as defined by the Pan-American Health Organization, the World, all the transfusion bodies, and common human decency. We will talk about the current process, not to belabor the merits, but rather so we can understand what happens. Realize many of us don't what is happening behind the scenes or within the scenes or on the scene, and therefore it is not straightforward to appreciate why the changes are being implemented. And most importantly, we would like to keep you abreast of what has been. For these slides, I thank Major Anthony Blake, who was the leader of a task force to plot the course of the blood transfusion service and to justify the things we do, and this slide justifies them well. It is well supported by organizations, international and abroad, that blood should be collected from voluntary, non-remunerated donors, and there should be certain assurances for the public for their safety. And the Ministry of Health has certain obligations to the national and international community. This is how the blood donation process has been prescribed and delivered for decades and decades. In effect, blood donors are recruited very much in the military setting, in that they turn up at blood transfusion centers at the behest of a healthcare professional for the healthcare system. To donate blood under the psychological, I call it stress, of having to determine the outcome of a loved one, which in itself causes a lot of stress and really affect how the service is operated thereafter. Because in effect, this donor who determines how the blood is distributed. This is donor who determines the quality of blood that is obtained. The process are well identified there. The blood is collected from nurses. The third of them don't meet the criteria. A lot of them come with hypertensive, from the shock of knowing what is wrong with their relative. The deferrals, which are defined as not being permitted to donate, having arrived at the center. There are many reasons for this, and past research has found that many of the deferrals are for reasons that people would be avoided, people knew beforehand what were the criteria for donation. For example, if somebody knew that the age limit is so on, so they would not come if they were outside the age limit. And then they knew that if one visited South America or Latin America, a certain period, and understood why, they would not turn up. But if they were aware that having been pregnant, one should not donate within a certain time, they would not turn up if they knew that beforehand. But the act of deferring somebody, I think pretty much disqualifies that psychologically from then on, from being a blood donor. There are deep feelings of rejection, and we must be attuned to those, and it's best to avoid. The blood collected is thereafter screened, which is very important to know that the screening is the last bastion of blood safety. And the initial security measure is getting blood from the correct type of donor. That type of donor, as we discussed yesterday, and continue to discuss the voluntary, non-remunerated blood. So the aim of this entire symposium is to ensure that we, as the minister was together, we build a pool of non-remunerated blood. It is estimated we need about 40,000, 50,000 of blood donations per year. But the safe and equally available, so no one is behind. Best had from voluntary, non-remunerated blood. It is very important that the blood donor pool be accessed from the correct places. If they are not, the risk of people donating without factors that would predispose them to be affected increases. So therefore, it's best to have people know this fact. The voluntary, non-remunerated blood donors being shown over and over again. If one collects blood from voluntary, non-remunerated blood donors, the risk of any kind of infection is virtually zero, just by virtue of why they donate. Blood is collected and then distributed on a basis of, usually it's a human being. And if it's freely accessible, then those most in need are transfused with priority, rather than those who have entitlement. Excuse me, entire service if the blood was collected from voluntary, non-remunerated blood. So these were the blood donations in 2020. Nationally, like I said, really we need about 70,000 units of voluntary, non-remunerated blood donations that are freely accessible to anybody requiring blood in the population. But the system of donation itself limits how much we collect, because people donate only when they come to their job. Relative meetings, and it's nobody's fault, that's how it's done. All people donate and are sure that they have enough blood to serve their family. The family is needs. So I have a small family, I donate twice. Good. But then well, theoretically, I donate twice and stop. If, however, voluntary unremunerated blood, I donate 3 times per year with no consideration to family or almost build up voluntary non-remunerated food benefits everybody, including. That is our goal. As you can see, most of the blood is collected at the European Medical Sciences Complex and is collected at various locations and throughout the country. One of the problems is that with how it is donated, limiting there's limited the option to transfer collected units from one center to the other is not as freely available because most donations are to a chit or donor. So it's not very straightforward to send some units from one center to the other. You have to break down that problem and that all blood is donated. So you see, our donations have gone down with COVID. This is a global phenomenon. And most of our blood donors continue to be family based blood donors. That means I donate for Dr. Dixon and donate for Dr. Dixon until it is decided Dr. Dixon doesn't need it. And by that time, this day expired. So it either expires and in the interim it remains unavailable for Dr. Kafinio. So we have to understand the true implications of these. Our blood donor deferrals are very high throughout, ranging from 87 to almost 50%. That means of every 2 to 3 people who came to the donation center, most times under distress, were deferred for 1 week. It's very costly. It's very psychologically traumatic for people. But relations. This is how blood has been dealt with in the past. It's collected at the 6 donation centers and generally processed into red cell plasma platelets at 3 centers so far. The Urbanus Medical Sciences Complex, the Forest-Green Center, which has been relocated to Federation Park after the complex T. The southern west, southwest RHA. So there's 3% for a population of 1.4 million. These centers then issue blood components to the said hospitals, public hospitals, which then service the adjoining private institutions. So there must be freedom of access wherever citizens present. I was speaking to a young lady from medical association this morning. She is too bashful to speak, but we get it. Because the story needs to be told all around. We need to be able to get it. Because any of us can end up anywhere, you can blood components. And it must be freely available. When I say free, I think that we coming back as well. Because free is always is the best way to put things, because I didn't intend to get into this here, but there must be some method of cost recovery. Because all of this happens at a cost. So there must be a way to meet the expense of the National Blood Transfusion Service in a method that is not profit driven. Yes, it's just expanding and expanding to maintain a service. And it's a vital service. And I trust that Professor Roberts and Dr. Wills will tell us how to by way of cost recovery. The patient does not pay, but the cost of the service is made up somehow. So this is proposed that there will be 2 processing and issuing centers for the country of 1.2 million. In the perspective, there are 3 such centers in the UK for a population of 50 million. It was found that anything that set up that was just inefficient. So they went from quite a few processing centers and eventually create for quality and for cost efficiency. It takes great professional training and quality assurance to run processing plant, and it is frankly unsafe to have to wait in our small land. This was commented several times. So this is planned to interest as such to be processing plant in the country. So to summarize the plan so far and tell you what we have managed to do so far. A date for which discriminations and credits has been announced is at the end of 2024. But we estimated the national need, we put that 40,000 units of voluntary application. We have done this training in collaboration with the University of West Indies to increase efficiency and effectiveness. So this has had the effect of motivating nurses and increasing efficiency. Perhaps we will see fewer Facebook updates. We plan to establish a national blood donor organization. From among the group that is currently doing voluntary non-remunerated blood donation, and to encourage other existing groups to join with that group in doing so. In collecting blood, the no shit, no credit. And we understand that all motivated by good. There are many ways the existing system, I don't think I have the system, how things are arranged now as sort of painted people into a zone of functioning. Only two options available, and therefore people took the options available. The first people along the path of voluntary non-remunerated blood donation. We would encourage our citizens to avail of it and clinicians to encourage relatives to register as voluntary non-remunerated blood donors. And we continue to use the long tongue twisting term because it's important that we appreciate what it means, what it will mean for a country when we will achieve it. We only give the stamp to your country to do it for something. So we plan to establish a blood donor organization soon. We establish new donor organizations among the groups who give us testimonials, expressions, encouragement, yes, in region. The separate party has been created. The national media has been very much included in our efforts. It's very important that we be aware so that reporting is balanced and the full understanding that adverse reporting, while keeping the system on its toes, would have the undesired effect of eroding confidence in what is very critical. It's a balance. We've been assured of international collaboration. You have heard on so many. So into the pathway. We are strengthening internal communications along all processes in the blood donation routine. We are updating the national blood transfusion policy. As we go down, we will establish voluntary non-remunerated blood donor programs at all RHA centers. I encourage organizations. Friday was telling me today about 41 clubs. These youth clubs, and just have a day and have them come and do a VNRD session at this center or that. Habits. We'll intensify community outreach, and this symposium is intended to be the start of that. Will increase mobile donor collections. I was thinking we will link the more implementation process. The national communicable disease facility that could be exchange dually used. Dr. Victor Wheeler later will tell you how we started the program today by taking our mobile units and shares to the community. We plan to convert existing donors to VNR. The last step will be to collect enough blood from all categories of donors while building the VNR and in 4 months preceding the date of discontinuation. We collect enough blood to meet 2 weeks of blood supply. Distributed to all our ratios on an equal basis beforehand to prevent some forward innovations like happened with criteria. So this we have done, colleagues. These are the people of whom I'm so very proud. For young people, their communities, their relatives, their friends, that good who've done VNR evaluation and brought us in the position we are in. These are some of time.
Thank you, Dr. Charles. Next on the agenda, we have Dr. Adish Singh. He's the Director of Women's Health at the Ministry of Health since 2017. He graduated in 1990 from the University of West Indies and has been a specialist in obstetrics and gynecology for over 25 years. He has always worked in the public sector in Trinidad and Tobago and has functioned as a specialist medical officer, UWI lecturer, and medical chief of staff. He has collaborated on research papers, medical textbooks, and has created a number of clinical guidelines, national policies, and other innovative projects that have resulted in improvements in maternal and newborn health. So we now welcome to the podium Dr. Adish Singh to present to us blood transfusion in women's health. Welcome, Dr. Singh.
So thank you, speaker. Hi. So my topic is something of to speak more on experiences. A little bit about obstetrics and gynecology. Some administrative things is which I think assist Dr. Charles and the team we have been doing. So, of course, the reason why we are highlighting obstetrics and gynecology is we are both in some largest reason of blood in some regions. Shortness is very for blood. Yes. But we are doing our best to try to reduce the need for setting or proactive and preventive things. So we do tend to see a lot of things like anemia. We test this all well. It shows that anemia is quite blood disorders as well. We are also we're picking up these. I was not experienced healthcare or work for healthcare until they are pregnant. So 50 states up to the first, we have to do some level of damage control. Of course, there are many cases in normal delivery as well as cesarean sections where there will be blood loss. Some of these are very unpredictable, quite massive. 10 minutes. So all of these, of course, contribute to blood loss, it's morbidity. In terms of gynecology side, of course, we have blood and blood transfusion in terms of our messages giving surgeries, oncology, surgeries, morbid, lots of fibroids or complications. 80% of our women at some point will be diagnosed with fibroids. Unfortunately, not all of these patients, of course, will require surgery. Hysterectomies and surgery, myomectomy surgery is quite important. We have on the agent, they are separate topic. Watch we have the now and view. So I'm just going to share some quick slides. We're going to share these slides. Data generation of data user is critical in terms of the way forward when it comes to projections. This is an important slide. It shows this was not fully charted before, where we can see monthly trends in terms of the number of babies born to be one of you that the decline on an annual basis. During the pandemic, we saw this. What does it mean for blood transfusion? Well, we will expect the use of blood into the it is we have actually less patients. Is quality of care. Our time is these. This data also comes from ICT. We have a clinical information system we have been using for the past few years throughout Trinidad and Tobago. Sally Grant is doing very well today. Use of the electronics, plugging data analysis. And in terms of using the absolute definition that we will show, you can see as 11 graphs we found a significant of our patients are considered 1 in 3 patients are considered immediate last trimester pregnancy. In terms of blood utilization, again, data. This is just one hospital. Both in obstetrics, generally there's a downward trend in terms of utilization. Again, maternal mortality is important. Before coming into the office in 2017, just like all of the countries, hemorrhage was the number 1 cause of maternal mortality. We no longer see cases from hemorrhage in our country. So we see more cases. Below the surface, we have less maternal mortality. We are also seeing quite significant morbidity in the background, of course. We're preventing these bigger things, but we need blood and blood transfusion. Children did very well. We're achieving SCG targets for this period. For the first time, we have and something we also have decided, but we actually look at below the surface, those AMS cases, but the significant portion are actually from hemorrhage. So data will support planning. Similarly, in the neonatal mortality, we've seen we're achieving we can improve here. 12 the slide was in the year 2015. We heard Honorable Minister yesterday championing all of the issues we have put off, but the health must take a stand forward. That's why we are working here. We are that's what we did in the territory. So we basically put targeted intervention, no resources. Screening. But this lots of interventions. They are also managed skills and drills and must be done during COVID pandemic. We also introduced drugs and the things in the formulary to be able to help reduce the give support or targeted and regional of gynecology. In terms of the administrative side, we do the directorate of based on how trying to use some of the in terms of how we get to the data which then all of the in the beginning to choose
Thank you, Dr. Stevenson, for that enlightening presentation. We are moving right along in terms of the program. Next up, we have Professor Roberts, Professor David Roberts. Dr. Roberts, are you here? Professor Roberts, are you online?
Yes, I am. Can you see me at all?
We can't see you yet, but we hear you loud and clear. Professor David Roberts is Medical Director for the pathology and NHS Blood and Transplant, which is essentially the blood service for England. He's a professor of hematology at the University of Oxford. Dr. Roberts is here to discuss the structure of the United Kingdom National Blood Transfusion Service. Can we please welcome Professor Roberts?
Thank you. I think you have to stop sharing so I can share my slides.
Okay, just give us 2 minutes, less than that, and share the text.
Okay.
So we're seeing you now.
There. Can you see the slides? Can you hear me okay?
Very good.
Okay. Well, thank you very much for inviting me to speak today. It's an absolute pleasure to be here. And we've already heard a lot about development of services. I'm going to tell you now about the services in the UK, but quite specifically in England. We spoke yesterday about collection, and I'm going to talk a bit more about supply and really also emphasize how the transfusion service is integrated to the delivery of transfusion medicine. I'm going to start with a little bit about the regulatory framework we work under and explain how we've developed our blood service, not just to deliver blood products, but also be an integral part of the health care in the UK. It's been extremely important that we not only supply blood, but monitor and help clinicians use blood. And the overall theme of that, which is something that's developed over the last 20 years, very different to when I was training, is that less blood is often more effective. And throughout the talk, I'll reflect how our experiences may help you in Trinidad and Tobago. So our regulatory framework, you certainly don't have to learn all this, but there is an act of parliament, an actual legal framework called the Blood and Safety Quality Regulations that sets down the minimum standards for safety and quality of all blood products. And then we have two regulators who report to the Department of Health. And one is the Medicines and Regulatory Products Agency, or MHRA, which regulates not just blood components, but all medical devices and medicines. And there's another agency that independently inspects and monitors the delivery of actual healthcare, not just we deliver to the care to donors and to some patients, but it monitors all hospital, GP care, mental health, and in care homes. And the Department of Health is also advised by an independent advisory group, which called SABTO, which advises on blood, tissues, and organs. We take that advice, the UK Blood Services take that advice, and they translate all the guidance into practice, into it's published in the Red Book, it's available online. So we have a legal framework, a regulatory and advisory bodies that report to the Department of Health, and our own committees that translate all that guidance into practice. So again, to emphasize what we talked about yesterday, that all our work and development of services is based on non-remunerated blood donation. And I think also very important to emphasize, as Kenneth Williams has already mentioned, that in order to develop and integrate services, it is absolutely dependent on confidence in supply of blood. And when our own services in Oxford were integrated, first of all, into a regional service, people in the hospital, this was only 20 years ago, were very anxious they wouldn't have enough blood because they were so used to having very local control. But those those anxieties were overcome. But it is clearly essential to maintain confidence in the supply of blood. And I spoke yesterday about the amount of blood cells we collect and our large donor pool. I mentioned how important, and I think people have already spoken about it today, how important it is to have recall and activation of donors. And that's really because it's very difficult to recruit donors. Obviously, if one person can donate 10 times, it's very important to encourage them to continue to donate, even if they've lapsed for a while. And we're all looking forward to how this supply of blood can really help deliver of services, particularly, I think, for sickle cell disease, where we now understand that exchange transfusion can be very helpful to avoid stroke. Now, we do collect blood with a mixture of centres and mobile teams, and not all our centres are in hospitals. Some are in the city centres, and this one here is in London, very close to Oxford Circus, and allows a lot of people to come and donate while they're out working or shopping. So we think that's very important. And our centres are also important because they provide space and facilities for the machines we use for red cell exchange, plasma exchange, and other procedures such as photophoresis. But the centres can't reach everyone, and 2/3 of our blood is collected by mobile teams. Now, to make collection of blood efficient, we've used 9-bed units, but it may be more appropriate to use smaller numbers of beds. It is quite logistically complex because these teams are based in centres, but each day they have to load onto a lorry all the equipment they need and to travel out, set it up, and deliver a whole blood donation session. And very importantly, their visits to centres or visits to locations are timed, so they come back appropriate to the number of donors. Some small towns we visit every month, but the smaller villages we may visit only every 3 to 6 months. But it really allows donors to travel less than 30 minutes. And in villages and small towns, this often became a very important community activity. The sessions have to be well organised to make sure there's sufficient areas for all the activities, including rest. We don't anymore, but we used to give people tea, coffee, and biscuits. So it requires a lot of organisation, but our donors and our staff are very enthusiastic to deliver these facilities. So in terms of manufacturing, we're on 3 sites, and that involves a lot of transport, because with only 3 sites in quite a large country, we have to take blood from the teams and from the centres, take them to London, Manchester or Bristol, test, and then return the blood to centres. So it's actually involves quite a lot of, we have quite a lot of transport. But one of the big advantages is to have centralized testing, not just for the regular infections we test for by nucleic acid, PCR tests for hepatitis B and C and HIV. We've just introduced hepatitis B core antibody testing to help exclude occult hepatitis B, where there are very low levels of antibodies and DNA. And we test new donors. Obviously relevant for the Caribbean is HTLV1 testing. We also gather platelets, both from apheresis, which reduces donor exposure, or we can make pools from 4 or 5 buffy coats to make platelets. Now, we have used our expertise in donor selection and handling substances of human origin and our quality services to develop other services. And we also send out teams to consent donors for renal transplants, facilitating about 4,000 renal transplants a year. We have a corneal eye bank and collect about 200 corneas a week. I've mentioned our involvement in pheresis for therapy and red cell exchange, but we also collect stem cells to enable stem cell transplant. And although these numbers are quite big, and I think Trinidad and Tobago is about a 50th of the size, but even so, you can see we can facilitate lots of other work that is very important for delivery of healthcare. We also have quite a big research program, and I'll just tell you about one research project where we've developed DNA typing arrays to type red cells, platelets, and white cells. It's actually very cheap now, and the cost is only about $20. But we will be able in the next 5 years to have extended matching of red cells for those who are chronically transfused, particularly sickle cell patients, provide HLA matched red cells for renal patients, and recruitment of platelet and stem cell donors. And obviously, to do this, it's very important to have donors who keep coming back, because you've invested more time and effort in typing them. But it really provides improved outcome for patients. So when we compare Trinidad and Tobago in England, I think what struck me is that really in terms of collection, you're really not so far behind in terms of units collected per 1,000 of population. So I think you must be encouraged. You're already making very good efforts. and to target more donors it's not so difficult to get up to the amount of blood that we use in the UK. I think it's important certainly to have more than one site. We had one of our major collections for manufacturing. We had one of our sites go down a few years ago, and we had to divide the work between other centres. So to have that resilience is very, very necessary. What we're able to do is to predict or to understand how much stocks we have in the system and to predict demand. I can see some of your demands fluctuate, but you should be able, we aim to have 6 days of stocks of red cells. And sometimes that's actually quite difficult for the units in high demand, such as for us O negative, group O or group O Rh positive units. And in fact, recently, this month, we had our stocks for those O-pos and O-neg dip below 3 days, and we had to issue an Amber Alert to hospital. And there was a nationwide appeal for donors, but the main problem was shortage of collection staff. We relied on hospitals to limit their stocks and the operations. They monitor blood use carefully. And there was a huge effort. And in fact, by reducing demand by about 20%, only 1% of operations have to be cancelled. And I think this emphasizes the very important role that blood services have to have in guiding use of blood. And I think this graph says so much that over the last 20 years, these are the number of units issued that were over 2 million in the turn at the millennium, and now there's 40% less. So an enormous amount of reduction in spite of older population, more cancer patients, and more sickle cell treatment. And this is a real change in the way we think about use of blood from when I was training. And a lot of it started with this seminal paper from Paul Herbert in Canada. And he conducted a trial that many people thought would never show equivalence, where he had a restrictive transfusion threshold of 70 grams per litre and compared it to a liberal transfusion threshold of 90 grams per litre for intensive care units. And I think we all know the result. In fact, those who had less blood did slightly better. It is applied to many branches of surgery, and for most surgery, almost all surgery, people are exactly the same if they have these lower transfusion thresholds. And ironically, we've been slightly slow in addressing our own populations in hematology, but transfusion thresholds of 70 grams per litre provide the same outcome as higher thresholds with no difference in outcome or quality of life. And Jeff Carson has examined in a Cochrane review over 10,000 patients transfused with a restrictive threshold. Blood red cell transfusions were reduced by 40% with no difference in mortality outcomes or specific important medical complications. And this is, I think, quite counterintuitive. We certainly didn't think this would be a way transfusion services would develop. And even more importantly, sometimes giving less blood is actually much better. And again, this was unexpected. A number of people compared restrictive thresholds for acute gastrointestinal bleeding compared with liberal thresholds. And you can see here a 35% reduction in mortality and a 40% reduction in rebleeding with lower transfusion thresholds. And I think this was completely unexpected. And I vividly remember being asked and prescribing lots of blood for our bleeding varices patients in the belief that quite wrongly that this would reduce mortality. And we now know that a restrictive threshold is actually much better. So in order to encourage people to have low thresholds and to, if people aren't bleeding, just to use single unit transfusions, we have national guidelines. And here, those guidelines are reinforced by transfusion committees, both nationally and locally within hospitals, and audits. And even now after many years, we're not reaching 100% adherence. It's getting up to 80, 90%. So that is continued work. We have a significant number of doctors and in the blood service do help to do this work. And there are other ways in which we've helped to reduce blood, and I'll just mention some of them, two of them briefly. The maximum blood ordering schedule, which actually limits the number of units that will be routinely reserved for standard procedures. And I think the important thing here is that this is a local agreement between the surgical team and the laboratory based on local practice. So it's not an imposition. And here's an example of one of the Bristol hospitals. Now, the important thing here is that blood has to be made available if you don't cross-match blood within 15 to 20 minutes. And it often relies on having two group and saves, one from outpatients and one on admission or preoperatively, so we can be assured, first of all, that the grouping is correct, and secondly, that there are no alloantibodies. But if that's true, we can issue blood very quickly. And you can see here, given that for some quite large operations, we don't cross-match blood routinely, but practice does vary. And you can see online that there's a survey, I can give you the reference, of all the hospitals in the Birmingham area. And there is quite a wide variation, but you can definitely reduce blood. And Dr. Sujit Singh did mention tranexamic acid. It's been shown to reduce mortality in emergency bleeding and trauma and maternal hemorrhage, but also it does reduce major surgical bleeding by 25%. And we're now encouraging all major surgery to patients to be given tranexamic acid. And again, even though this is well established, adherence is still only 70% in our orthopedic surgeons. So a lot of work continues in this area. So we're involved not just in supplying blood, but helping the correct use of blood. We're also involved in monitoring side effects from blood and blood transfusion, right from donor screening to transfusion and follow-up of patients. And there are reporting systems, the SHOT system and the SABRE system for adverse event and serious adverse events. And those incidents are collected together to provide reports, to share what's happened, and to so we can all learn about this. And the Serious House of Transfusion was one of the first hemovigilance systems, started as a voluntary system, but is now mandatory. And it's really shaped the strategy for better blood transfusion. And specific findings have helped reduce bacterial infection by showing how skin cleansing could be improved. It's reduced transfusion-associated lung injury by avoiding plasma from female donors, and recently is concentrated on reducing human errors. So an incredibly important system, and one which is hemovigilance systems are being set up right around the world now, and something I'm sure we'd be very happy to help with in Trinidad and Tobago. So I've talked today not just about, we talked yesterday about collection, we've talked about clinical management and processing, but these systems are also the systems that you need to develop an integrated service are important. The transfusion committees, guidelines and hemovigilance, sharing those audits and protocols and better stock management. And I haven't talked too much about financing, and there are different ways to finance services. In some parts of the UK, there's a block grant for delivery of services. In England, we negotiate a unit cost for blood, which we estimate will cover all our costs. It's called the blood price, and we renegotiate that each year with hospitals. And it is a way of making sure that our costs don't escalate, and also by making sure hospitals have to allocate a budget to blood, make sure they have some encouragement to reduce the blood use. Now, this all seems quite a lot, but I can hear so much is going on. I think we have to be very optimistic for the future and remember that Rome wasn't built in a day. From over a working lifetime, there are enormous changes that can take place. And I'm confident, I think we all have to be confident that very, very soon you'll have a great national blood service based on voluntary, non-remunerated blood donation. And as I said yesterday, I think there's an enormous amount of help. Obviously, in the UK, we're very willing to help through the British Blood Transfusion Society and the blood services, but also from many international services will be able to help you. And I hope you develop links with the African blood services and regionally to share your experiences and to learn from them. So I really want to thank all our donors and staff who provide such wonderful service. Dr. Kenneth Williams for inviting me to speak. It's been a great pleasure and very enjoyable to hear of the progress you're making. My colleagues, I'm not going to name them individually, but who've helped provide services and provide slides, but also to have formed a lot of the thinking, and more broadly in NHSBT and blood supply and donor experience, who've developed the services I've described today. So thank you very much.
Thank you, Professor Rollins. We move on to the next item on the agenda. Dr. Keith Wilson. Dr. Wilson graduated from the University of the West Indies, Monash, Jamaica. General medicine postgraduate training was undertaken right here in Trinidad and Tobago. Specialist training in hematology and transplantation in London, St. George's, the Royal Marsden, and St. Helier Hospital under the auspices of the South Thames Deanery. He then went on a joint appointment with the Welsh Blood Service, where he was the lead consultant for 8 cases and the medical director of the Welsh Bone Marrow. Dr. Wilson maintains an interest in transfusion medicine and continues to speak at national and international conferences. He is also actively involved in the advanced therapies agenda in Wales. In 2020, Dr. Wilson founded the Wales Cellular Therapy Consortium, primarily to further translational research into advanced therapies, but also to serve as a platform for interested researchers to benefit from its transplant database. Dr. Wilson will lead us through an overview of the Welsh transfusion. Can we welcome Dr. Wilson?
Can I thank the committee and Kenneth Charles, my long-standing friend, for inviting me to join you in your symposium today. Hopefully you're seeing my screen. Just let me know when it's visible.
It is.
Marvelous. Thank you very much. So I'm going to speak to you about the Welsh Blood Service. In some ways, our history is linked with that in England. So I had to sort of anticipate what David was going to speak to you about. And I'm going to give you something slightly different so that we don't overlap too much. So I'll start by giving you greetings from Wales. For those of you who are wondering what's that at the top, it's Cavashian or Gymru. And I'm going to give you a brief introduction to the blood service and then share some experiences of mine relating to strategies for sustainability. David already covered standards and surveillance. I have just 1 or 2 slides about that before we end. So in Wales, the NHS is divided into 7 local health boards, and these health boards have responsibility for both planning and delivering healthcare services within their catchment area. We also have 3 NHS trusts, all with an All Wales remit, the Welsh Ambulance Service, Public Health Wales, which is embedded in several acute hospitals, and they provide not only microbiological services, but on a All Wales basis, our national screening programs such as breast, cervix, bowel, and so on. We also have a special trust called Voluntary NHS Trust, which previously did house some of the screening services, but now houses the Welsh Blood Service as well as the Voluntary Cancer Centre. So that's just to put the Welsh Blood Service in context of the Welsh NHS. Some of the differences in terms of where we deviated from the path in England came about because of devolution within the UK. And the first referendum was held in 1997. It was a very close result in favor of devolution, but it led to the Government of Wales Act, which led to a National Assembly. When that was amended in 2006, we had a Welsh government that had lawmaking powers, but those laws had to be approved by Westminster before they could be before they could take effect. And a second referendum in 2011 resulted in a larger margin in favor of devolution. And so there are devolved areas of responsibility, including health, that the Assembly government is responsible for. So you would have heard yesterday that the blood transfusion service as a national service started in 1946, and that was covering both England and Wales. Initially, there were 8 regional centres. They later expanded to 14, and the numbers have sort of changed with the years. In 1993, in England, the National Blood Authority was formed, and the following year, the NBA assumed executive control of not just the blood transfusion service, but all the associated facilities and services that you've just heard about. And at that point, the NBTS in Wales retained responsibility for Wales, but only for South Wales. And I'll show you a map later explaining why, because North Wales, separated geographically from the south by a mountain range, continued to be serviced by the NBA under the auspices of the Liverpool Blood Transfusion Centre. In 1997, the service moved to new purpose-built facilities. By 1999, the name was changed to the Welsh Blood Service, and it was 70 years before the Welsh Blood Service assumed responsibility for all of Wales, including North Wales. Jeff Poole, who previously worked at the International Blood Group Reference Laboratory in Bristol and who was subsequently director of the Welsh Blood Service, wrote a lovely article detailing the history of the transfusion service in Wales, and I commend this for your further reading. Now, this is a diagram of the catchment area of our transplant program, which covers 6 of the 7 health boards, covering nearly 80% of the Welsh population. And this mirrored exactly the catchment area for the Welsh Blood Service until it assumed responsibility for North Wales. And the reason can be seen if you look at the map of Britain, that just moving east from North Wales will send you into Liverpool. So strategically, it was easier for patients and for the service to be supported by the blood service in England. This was the original site of the NBTS in Newport before it moved to Ridlava, which actually is very near to where I live. If you keep going up this road, you'll eventually come into my village. And this was actually the site of a previous US military hospital, until the blood service moved to its purpose-built facilities in 1997, and it is here today. So similar to England, the blood service does not just provide blood, as it were, but different from England is the fact that the blood service is actually funded centrally by the government via the Welsh Health Specialised Services Committee. And that proved challenging when we tried to introduce measures consistent with the Better Blood Transfusion agenda, because hospitals in Wales are not charged for the blood that they use. So there was no financial incentive for them to use less blood, because there would be no financial remuneration that they could reinvest locally. So we had to find other means of persuading and encouraging our colleagues that using less blood was in the patient's interest. And here you can see some of the other departments within the blood service, the Welsh Transplantation and Immunogenetics Laboratory, which supports the solid organ transplant program, as well as our own stem cell transplant program, the Welsh Bone Marrow Donor Registry, which recruits donors from the blood donor base to support transplantation in the UK as well as abroad. We also host the UK National Quality Assurance Scheme for histocompatibility and immunogenetics. And there is a quality assurance department that is part of the blood service, but acts independently to monitor compliance with the various articles of legislation that you just heard about. And they also perform external audits for us, the transplant center as well. And I'll say a little bit more about the Better Blood Transfusion team and hospital transfusion committees. So I'd like to say a little bit about sustainability and the importance of converting data into useful information. It is possible to have data, but by not analyzing it, you are not wiser regarding what it's actually telling you and the state of play. And we were in that position as well. You've seen a more up-to-date list of the tests that are routinely performed, but I've decided to not update these slides to give you the historical context. So in around 2000, 2001, we noticed that increasing numbers of donors were being deferred when they presented for donation because donor selection criteria were becoming increasingly stringent. And here you can see as a percentage of attendances, we went from about 90% of donors going on to give a successful donation to about 83%. Now, during that time, demand from our customer hospitals continued to increase. So like in England, where we had to negotiate how much hospitals thought they would need and then meet that demand, unlike in England, where you could work out a price that would then cover your costs, we simply had to manage within the budget that was given us by the government. So clearly, if we couldn't persuade hospitals to use less, and we were finding it more difficult to use our donors, one could easily see that a potential crisis was looming. And as you've heard, these are the number of donors coming annually, about 120,000. And you can see that the effort taken to get donors to turn up at all was becoming increasingly challenging with time. And as you would guess, the less effort you need to get a donor to turn up, the less effort you need to keep that donor as a regular donor. So it's important for you to learn where you tend to get people who are most responsive and put your efforts there, because they are the ones more likely to become regular donors who actually donate the core of the blood that's collected. So if we look at the net change in donors. So every year donors leave the pool because they may come to the age where they are no longer allowed to donate. They may have acquired conditions that now make them ineligible. And then we get new donors coming into the pool. So you can see that even though the net change was decreasing, it was still positive up until the turn of the century, where the net change was negative. And that was translated into a donor base that gradually increased with time, but then started to decrease. And what was particularly challenging in Wales is that even though a donor can donate at least twice per annum and up to 3 times if they donate exactly on time, here you can see that donors on average were coming 0.83 times per year, roughly equivalent to once every 14 months. And this was a time when I was still at the blood service, and we looked at the data and we were able to predict that if the trends continued unabated in that demand continued to increase at the same level and donations continued to decrease at the level that they were going at, that somewhere around financial year 2006-07, we would be producing less blood than the hospitals wanted to use. And in 2003, I created a balance sheet where in that year, we archived 34,000 donors. We reinstated 10,000 who had been temporarily deferred. We had recruited nearly 17,000 new donors. But if you look at the net balance, it was a little over 6,500 net loss to the system in 2003. One of the advantages of being a small country is that there are not many layers to government. And this data was presented to the chief scientific officer, who then went to the government via the Minister of Health. And they agreed to establish a better blood transfusion team. And this was established very shortly afterwards in early 2004. They were funded centrally by the government, and the aim was to implement the better blood transfusion agenda in Wales, which was defined in the Welsh Health Circular 2002-137. And we appointed a lead consultant, a manager, and 3 transfusion practitioners in the 3 largest users of blood, who together accounted for 80% of blood use in Wales, despite the fact that we have 20 hospitals. So we had one in Cardiff and Vale Health Board, in Cardiff, in Aneurin Bevan, sorry, this is Abertawe Bromwgannog Health Board, which is now Swansea Bay in Swansea, and Aneurin Bevan in Newport. And they revolutionized practice because they were able, via the hospital transfusion committees, which were already in existence, to develop, support, disseminate best practice. And we already had an advocate who was keen on cell salvage. They established a cell salvage database. They encouraged and helped in the performance of local and national audits. And there was an ongoing educational program. And one of the key things that they were able to do was to establish a training program where we have non-medical people who can authorize blood transfusion. So the Welsh Health Circular was exactly the same as the Health Circular in England, just had a different numbering system. And here you can see the key aims of that circular. And this is the answer. Here you can see in that early turn of the century, the blue line represents blood usage in Wales, and you can see it was increasing, whereas in England, they were already managing to get hospitals to use less blood. But you can see that from 2004 onwards, the fall in the use of blood in Wales mirrors that in England, showing that despite the fact that we did not have the incentive for hospitals to recoup money by transfusing less blood, we were able to get the same result through education and continuous persuasion. So that was reducing demand. Now, and that has actually made it very easy to, well, not easy, but easier to maintain the level of blood that hospitals need commensurate with current practice. Now, one other means of addressing the conflict between demand and supply is to increase supply if your demand is insufficient. And here you can see you can increase the frequency of donor attendance, and you need to make it easy for the donors to attend. So we go to universities, we still go to workplaces, we use mobile units, because whereas it is good to have a static unit with all the bells and whistles where people can have a good experience, it is important for it to be convenient for people to donate, and therefore to be where the people are. And then one thing that I'd just like to mention is something that I have previously discussed with Dr. Charles, and that is the prospect of collecting more at each visit through automation. So I already showed you that whole blood donors tended to attend less than once per year, equating to every 14 months. And we wondered whether we can collect more at that time when they did turn up. And we wanted to look at the use of multi-component collection, and we evaluated a mobile apparatus called the Baxter Alix, which was able to collect a double unit of red cells processed in the collection procedure, and you would get packed red cells which were leukodepleted at source, so needed no further processing, but you still simply had to test the donor for pathogens. So this is the Baxter Alix. It opens up and sits in its own carrying case. I'm not going to show you all the details of the evaluation, but we carried it out using apheresis donors and apheresis operators, but we also compared it to whole blood donors and whole blood operators who had no prior experience of apheresis, but were trained to use the machine. And here you can see the consistency in terms of the hemoglobin content per unit between the two bags, as well as the hematocrit. And of course, the trained apheresis staff, and absolutely no difference with the relatively untrained whole blood staff. So if you have donors who meet the requirements and may only attend once a year, then one option for those who have hemoglobin of a sufficient level is to collect 2 units at that visit, and therefore you maximize the output per visit. This is just the team. This is Lisa Griffiths, who was the, oops, where have I gone? Yes, so this is Lisa Griffiths, who was the manager then, Linda Mills, who was the associate specialist, and other members of the team. And here you can see a donor looking suitably chuffed for donating his double red cells. Very, very briefly, you've already mentioned the different standards that you are adopting internally. There are standards available. It's important to not necessarily try and reinvent the wheel, and you may join or simply be affiliated with other associated associations that have spent the time developing these. You've already heard about the shot and saber schemes, and I'm sure these are things that you can engage in, at least some of them, and therefore have something that is already tailor-made that you might want to adopt either in whole or in part as you go forward to see the effectiveness of the different measures that you are putting in. I'd just like to end by advocating clear messaging, which should be simple but specific. I'm sorry that this is fuzzy, but we need 350 blood donations per day in Wales, and this was designed by a university group. It's on our website, saying we need 350 donors to come forward every day to supply our Welsh hospitals. And you already have your target of 20,000, so you can think of some snazzy ways for people to engage with that target that you are aiming for. Believe it or not, if you look at the patients in the age group of 17 to 70, only 3% of donors or of people in that age group are regular blood donors. So the good news is you actually don't need to recruit a significant percentage of the eligible population to have a sustainable blood donor base that is entirely voluntary and non-remunerated. Sorry that these slides are fuzzy, especially since I said you should have some clear messaging. And remember as well to celebrate your successes. This is one of my patients. I'm showing you her picture because it's on our website, and she has a story on the Welsh Blood Service website saying thanks to the blood donors whose blood she needed to see her through her leukemia treatment, as well as her stem cell donor for her transplant. And she was happy to be able to celebrate her wedding after the event. These are 3 people from the same family, 3 different generations. Not only are they regular blood donors, but they have each been selected as a stem cell donor to support a transplant recipient. And when one considers that your lifetime chance of being selected as a donor is only 2%, to have 3 members in the same family is a significant achievement. And I had the pleasure of interviewing them and speaking about it as a promotional piece of work for the blood service. And of course, in the spirit of celebrating, I just want to congratulate the Trinidad and Tobago Society for Hematology and Blood Transfusion, and Kenneth Charles in particular, for this first symposium, and hope that it will be the first of many to come. Thank you for your attention.
Thank you very much, Dr. Wilson. Next on the agenda, we have Dr. Victor Wheeler. Dr. Victor Wheeler is a consultant obstetrician and gynecologist at the Tobago General Hospital since 1996 and the medical chief of staff since 2019. He's a former president of the Trinidad and Tobago Medical Association in 2004 and former member of the medical board of Trinidad and Tobago in 2000. Former independent senator in the Parliament of Trinidad and Tobago from 2010 to 2015. He's about to speak to us on voluntary, non-remunerated blood donation in our sister island. Please, let's welcome Dr. Victor Wheeler.
All right, good morning. Thank you. I hope you're hearing me.
Yes, we are.
Right. I must apologize for not showing my video because where I am, the internet is a little bit unstable. All right, I must thank Dr. Charles for allowing me to present just for a few minutes on the Tobago experience on voluntary non-remunerated blood donation. Next slide. So our aim in Tobago was to target special interest groups, and also the aim was to bring blood donation closer to the communities, whether it's through a health center or a community center or at the workplace. Next slide. So during the COVID experience from 2020 to present, we did realize that there was a reluctance of persons generally to come to the hospital to donate blood. Part of the hospital was used to treat COVID, and because of the fear of COVID, persons were very reluctant. And we actually saw a dramatic reduction in the number of persons coming forward. So we then decided to target health centers throughout the island where we would bring blood donation closer to them, away from the hospital. And our first blood drive was actually at the Buku Health Center, which was on the west of the island. Next slide. Now, we had initially attempted to get the mobile unit brought to Tobago from Trinidad, but because of some challenges with it, the Tobago Regional Health Authority, on the advice of Dr. Charles, decided to purchase 2 blood donation chairs, which we can transport anywhere on the island. We had medical oversight provided for this donation through the Trinidad and Tobago Medical Association. And we also had an efficient transportation system to transport the donated blood from where it was collected back to the blood bank. We also got assistance from the National Blood Transfusion Center in terms of nurses. In Tobago, we have limited nursing staff to take the blood. So if we have to have blood donated at another site from the hospital, we have to have additional staff. So the National Blood Transfusion Center assisted us with a nurse, and we also, because we had to be collecting blood at another site, we needed additional equipment, which was provided from them. It was loaned to us. Next slide. So this is some of the equipment that we would have used: PCT, hemoglobin meter, blood mixer and scales, laptop for data entry. Because the ministry had launched whereby you can register online. We had laptop to allow persons to access that. We also brought whatever was required for the blood donation. Next slide. Advertisement for the blood drive was also important. We had a television interview the week prior where myself and the blood transfusion nurse, blood Dr. Charles, was able to explain to the public this new process of voluntary non-remunerative blood donation and the benefits of it. We launched a social media campaign, including flyers, and we also involved the Tobago House of Assembly A representative, who was also the Secretary for Health of the Tobago House of Assembly that actually runs the island's affairs. Next slide. That first blood drive was held in July of 2022. We had 8 persons attending on that day that were screened, and of that 8, 4 were donated. One of the concerns, because we chose a Friday for the donation, which was before a weekend where there was lots of activities. Several persons indicated that there was actually a reluctance to give blood because it might affect them during the weekend, and this is something we have to work on when we are educating persons when coming to give blood. Next slide. So we have another blood drive planned for November, which is next month, and we've actually chosen a community center, and this is being done in conjunction with the Anglican Church of Trinidad and Tobago that is celebrating 200 years. The Anglican Church have been advertising the blood drive among their members. Next slide. And at the same time, we're having discussion with the police service, another target group for us to get donors from, where we have involved the police nurse and the police doctor to assist their members with the online registration, because with this online registration, they are able to see for themselves whether there's any medical condition that might preclude them from donating blood. And the system also assists them in making appointments at the blood bank. And the other aspect of it is the nurse and the doctor would encourage them in voluntary non-remunerated blood donation. Next slide. So this was just a brief outline of what has happened so far in Tobago. The drive is important, it's ongoing, and I just want to give special thanks to Dr. Kenneth Charles, who has been advising us throughout this process. I thank you.
One, put up a child. No problem. So the question is, with respect to the screening of the blood units after it's collected, what pathogens do you test for, particularly in Trinidad?
Good question. So the pathogens are recommended for so it's only routine ones to use guys for the testing of the screen blood. We have the one. So it's so interestingly, we have 1%. Go forward.
Who did the online meeting? They still need
But let's not determine the child.
What an excellent presentation so far. This question, is there any need as COVID in London is received, but not as being transfused, the risk of transmission of COVID or other viruses like flu viruses?
Thank you for your question. Topical. There's no need to test for COVID because there is no evidence that transmitted by blood transfusion or donation. So the most of the things related to COVID were cross-infection, possible cross-infection of or from staff. So therefore the appropriate measures were adopted. Following COVID infection, somebody could donate blood if otherwise eligible, like 28 days after the symptoms have resolved. And definitely there is no deferral period having had a COVID vaccination. I think now that we probably are blending it a little bit because some people feel unwell after the vaccine itself. We have our time for evidence with the need for the vaccinations for the weaning children. Have I answered all your questions?
We have a comment from the audience. Hi, good morning, everyone. Great presentation, great work. I am actually a recipient of blood donation. I had my daughter back in 1992 units from Policy Chapter. The Dr. Wheeler would have been around then, and eventually my child. Dr. Wheeler child would have been the doctor back then. Then I eventually went up to Kenneth Child after I visited the blood bank to find out exactly what happened from that day. So I want to say thank you God so much. And what is really is knowledge is power. So we need to educate the public more about blood donation. And I really see all the blood works stuff. I think we need to get that up and running because I don't need to cut out the having to back there. So I was tested and everything. I am vaccinated and I started only last year to get blood after everything that happened to me back in 1999 with my daughter. So thank you all so much.
Maybe I say congratulations to Deborah, the daughter who just graduated from UWI.
Hi, we have a question from the audience, specifically to Dr. Charles, and then I have a follow-up for Dr. Wilson online. The audience member wanted to know whether you would consider taking 2 units of blood from the same person simultaneously, like Dr. Wilson suggested.
If the technology becomes available, as it should and will eventually, we will. But as it stands, we don't have those separated. And a big part of the reason for that is because of the manufacture and its collecting. The assurance that it is free of infections is not as much. To get the machine infected. So it really depends on how voluntary, non-remunerated blood donation pays. The major risk of infection is 0% to make all these other things possible. Okay, it will be done. What fast information?
Thanks for that. And for Dr. Wilson, for those patients for whom you take 2 units of blood, do they have more side effects post donation?
Okay, so we didn't introduce this routinely. So we only did the pilot. The side effect, first of all, we didn't do it in first-time donors because first-time donors have a higher reaction rate to the donation process anyway. Secondly, you had to have a certain hemoglobin. I think the cutoff was it had to be a minimum of 140 grams per liter. So these, in practice ended up being men of a particular size who had the requisite hemoglobin. And certainly comparing, since they came from the regular blood donor pool, I didn't show you the slide that documented their feedback, but they found it no different from their normal single unit donation process.
Thank you very much, Johnson. Now we have another question.
My question, follow-up from Dr. Ryan. Regarding the COVID-19 vaccine, does it matter what type of vaccine, IFIDs, RNA, the American virus? Two different.
Thank you, Dr. Kutu. What I'm saying is based on the vaccine that we use here, so quite complicated, so different, so where we lie 10 minutes. For us, we use how it applies to the ones that we use. Thank you.
We have one last question on if there's someone else interested in the audience. This is from someone in the online world who is asking, what is the upper age limit referred to by the UK presenters, when people no longer are able to donate, and he or she would like to have that same information for the local setting. So we'll begin with either Professor Roberts or Dr. Wilson. What is the age limit that you all utilize in the United Kingdom? And then you'll hear what's the age limit we use in Trinidad and Tobago.
Shall I go? So the upper age limit is 70, although I know that there was a little bit of pushback about that because some of our donors, when they reached, especially regular donors who have donated all their lives, when they got to age 70, they said, well, what is the difference with me today compared to yesterday? Because yesterday you would have taken blood from me, today you wouldn't take blood from me. So I know at the time we were considering how further it could be pushed. As I said to you, I stopped working directly with the blood service in 2006. So certainly up until that time, the upper limit was 70. I don't know, David, if we've since had some pushback, and once they're fit, they can continue. But certainly that's the level that I'm aware of.
Yes, that's right, Kenneth. We accept new donors up to 66, and then you can carry on till 70. I think after that age, the risk of medical deferral is relatively high. And we have a lower age limit of 18, managing consent. I think some other services have 17, but we haven't discussed it so much, but the rate of reaction is higher in the very young donors. They're much more likely to faint. And obviously you can reduce that risk by monitoring them carefully, encouraging them, and there are various other, we're actually doing a very big trial to reduce faints. But I think there are problems with very young donors. So, and even in the 18 to 21, I think donating perhaps once a year, and then increasing as you get older might be sensible, but there are no fixed guidelines on that. And as I said yesterday, it's the men can give more blood. They don't come forward quite as often, but I think they're particularly valuable donors.
Do you hear me online? Unless you hear some holding it closer. For the local health system, the ruling has conventionally been up to the people first-time loan and up to 55 for regular blood loading. And most recently, we've taken the decision, and it may not have translated to all the donation centers as well, but it has started to remove the upper limit and apply the same donor criteria, fitness and other things that would apply to anybody. If you're well enough to donate, then do so, or improve the training, facilities, and the follow-up and donation centers. I will share with you, there was a 78-year-old man who's very happy to be in the state, having been put off the list when he turned 65. 7 years, everything happy, no problem. So, yeah, so we're seeking to remove the upper age limit for that advisor. The other safety measures we assume will protect people who are unfit in any way, so we can remove the age discrimination that and please help us to grow by reporting the experiences. It's a work in progress.
Thank you very much. We are now into our break section. So please visit the booths outside and enjoy your coffee break. Right? We'll be back in here for, there'll be a 10-minute coffee break. We'll be back in here for 11:20. There unfortunately is no eating inside, so please enjoy your snacks outside. Thank you. We'd like to thank all those that came in relatively on time. We are going to begin our second session soon. He is there, so are you ready? Can we start the second session? Okay, now leading off this next portion of our program, we have Dr. Carol Hemorrhage. She's going to talk to us about the 10 commandments of blood transfusion. Dr. Carol Hemorrhage graduated from the University of the West End in Mona campus and is currently completing her postgraduate studies in hematology in London, UK. She has worked at several leading national and international centers for hematology, including the Mount Hope Hospital, King's College Hospital, University College of London Hospital, and is currently at the Royal Free Hospital in London. She has been actively involved with medical education throughout her career and has had formal roles in medical student teaching, most recently for students of the University College of London. She is passionate about social aspects of hematology. Dr. Hemorrhage will be presenting on the 10 commandments of transfusion. Let's welcome her, please.
Thank you. Good morning, everyone. So today I will be presenting the 10 commandments of blood transfusion. My presentation today will be a whistle-stop tour of several essential tenets of blood transfusion that we have briefly touched upon with our previous discussion and will discuss a bit later with some other excellent presentations. These principles were adapted from the NHS blood transfusion 10 commandments and serve to underpin the safe and effective transfusion practice. Blood transfusion is one of the most common procedures for patients in hospital, and so it is imperative that clinicians are well informed about the appropriate process and practice. Knowledge of transfusion medicine has a profound impact on transfusion outcomes, and variations from standards and practice may jeopardize patient care. In 2014, a study set out to assess clinicians' knowledge of blood transfusion practice and treatment regarding blood transfusion. This was a descriptive cross-sectional study using a self-administered questionnaire comprising of 35 items, which were designed to assess essential knowledge of transfusion medicine for resident doctors. And a total of 85 residents responded to this questionnaire with an overall mean score of only 48% for correct answers. Whilst a drawback of this study was that it was a very small center, it still highlights the importance of ongoing education, especially for doctors who will be prescribing these transfusions. So bearing this in mind, we'll go on to our fifth commandment. Transfusion should only be used when the benefits outweigh the risks and there are no appropriate alternatives. So for our first point, this is important for several different aspects. As far as possible, we do aim to avoid unnecessary transfusions to patients. Red blood cell transfusions are frequently overused and are associated with an increased risk of patient harm and added healthcare costs without conferring additional benefits. Evidence from clinical trials shows that restrictive transfusion strategies, which we briefly touched on earlier, which is such as transfusion 1 unit at a time, all the way using a lower hemoglobin threshold, do not increase morbidity and mortality among a diverse population of hospitalized patients. Published international audits describe inappropriate rates of red blood cell transfusions of 22 to 57% in a variety of clinical settings, including hospitalized inpatient, operative units, and emergency departments. Unnecessary blood transfusions may expose patients to harm and may occur without the transfusion even having any additional clinical benefits. So that's important to bear in mind. Also important to remember is that blood products are costly to collect and administer, And they are a gift from your blood donor, and so appropriate use of these is always important. Conservative blood use, i.e. restricted transfusion practice, is recommended in stable non-bleeding patients by NICE guidelines and choosing wildly campaigns in Canada, the UK, and the US. So recommendations from these focus on two major clinical decision points: the hemoglobin concentration at which blood transfusion is considered, and the number of red blood cells that are being administered at the time. So this takes us on to our next three commandments, which expand further on this principle. So commandments 2, 3, and 4, results of laboratory tests are not the sole deciding factor for transfusion. Transfusion decisions should be based on clinical assessment underpinned by evidence-based clinical guidelines, and not all anemic patients need transfusion. This will actually take us on to a very good presentation that's coming up next on patient blood management by Dr. Friday. We'll talk a little bit more about it now, just about the evidence supporting these commandments. So evidence from many systemic reviews and meta-analysis suggests that there's actually no increase in morbidity or mortality with restricted transfusion practices compared with liberal transfusion in a variety of clinical settings. And the definition of restricted transfusion practice varies, but typically clinical studies consider a hemoglobin range of about 7 to 9 grams per deciliter for restricted practices, compared to liberal, which uses 9 to 13 for the liberal transfusions. In 2018, meta-analysis that was done, this used 26 clinical trials, which was about 50,000 patients, and the 30-day mortality was no different between restricted and liberal transfusion strategies. Our next commandment is one that is often overlooked, however, it's still very important to remember, which is discussing the risks, benefits, and alternatives to transfusion with the patient and their consent. So I think remembering the patient's experience throughout the process is very important. Whilst we may already try to bear this in mind, a qualitative study has been done to examine this and suggested that patients want more information and more autonomy when it comes to the procedure of receiving a blood transfusion. Very few studies have been done which examine the patient perspective. However, there's one that I found that sought to identify how well patients understood the role of blood transfusion in their care and whether it causes them any discomfort or anxieties. And this was basically done over a 5-week period in a hospital in the US and identified 4 clear themes emerged actually, which were paternalism and decision making, patient's knowledge, blood safety and administration, and the nurse's role in transfusion. The participants said that because the physician decided that a transfusion would take place, they didn't understand that there may have been other options for treating their anemia. Pre-transfusion materials, when these were given, did not adequately explain risks and benefits of the procedure, and patients still felt a bit of anxiety. Participants also expressed concerns about the safety of the blood supply, although many of them went on to state that the nurses actually put them at rest and they valued their nurses' opinion. So these qualitative findings do suggest that clinicians may be missing opportunities to improve patients' knowledge and comfort with blood transfusion, and they can better meet patient needs before, during, and after the procedure. For the following slide, I combined 3 commandments into one, which highlight best practice and just important to remind ourselves of. So commandments 6, 8, and 9, the reason for transfusion should be documented in the patient medical record. The patient should be monitored throughout the procedure, and failure to check patient identity can be fatal. So this is always ensuring that at certain checkpoints during this process, we ensure we have the right patient for the right blood. Our next commandment relates to our important area, blood transfusion, which is massive hemorrhage. We have briefly touched on this before with our obstetric hemorrhage, and we will be discussing further with regards to massive hemorrhage in GI cases. Major hemorrhage is a clinical emergency that results in increased morbidity and mortality, and practice guidance is important to reduce these risks. delayed recognition of bleeding continues to be one factor for adverse outcomes in the management of major hemorrhage, which we've seen recently in our recent shock. While it seems intuitive that rapid and early transfusion of blood components in a bleeding patient will improve survival, the biggest takeaway from this is that actually communication and coordination between the clinical team, the blood transfusion team, and the hematology team where needed was actually the key and the underpinning principle for optimizing the delivery of safe and effective transfusion response and enabling better use of resources. Which will take us actually to our last commandment, and I will conclude. Education and training underpin safe transfusion practice. There's an abundance of studies that demonstrate the ongoing benefits of strengthening medical education in hematology and blood transfusion. Continuing education improves employee and clinician knowledge and better equips them to care for patients and boosts confidence, so that we should continue to foster an atmosphere of lifelong learning. Thank you very much for your attention.
Thank you, Dr. Maharaj. Now we go on to the next item on our agenda. Dr. Melissa Friday is an undergraduate of the University of the West Indies in the London campus. She recently completed specialization in the United Kingdom at the Sheffield Teaching Hospital. She's interested in furthering hematology care locally and regionally. She will discuss patient management. Please let us welcome to the podium Dr. Melissa Friday.
Good morning. I'm just going to talk about patient blood management. So the overview, what we'll cover today is what is patient blood management? Why is this important? Who benefits from patient blood management and how we apply this in our clinical practice? So what is patient blood management, or is called PBM for short? It is a multidisciplinary evidence-based approach to optimizing the care of patients who may require a blood transfusion. It was initially introduced in regional patients, but it has now been applied to all patients in the healthcare system. It was officially introduced by the World Health Organization in 2011, and it aims to reduce the inappropriate use of blood and its components. What is important to note that PBM isn't about restricting transfusion, it is about preempting it where possible. And the overarching aim of PBM is to improve patient outcomes while saving healthcare resources. So there are three pillars that combine PBM. The first is detection and management of anemia, and is minimizing of blood loss and optimization of coagulopathy and optimization of the patient's ability to tolerate. So these three concepts are what we call the pillars of blood management. So why is it necessary for us to all have patient blood management protocols in our hospital? Well, one, as we have covered here yesterday and today, blood is a scarce commodity and it should be used appropriately. We have a responsibility to our donors to use the blood products effectively. While the risk of transfusion associated complications are low, they still exist, so we must ensure that blood is only given when needed, and it is cost effective because there is a cost associated with collecting and preparing all blood. So this is data from Western Australia, and they are actually the leaders in patient blood management worldwide. And they have shown from their data in 2014, this was into a review of 600,000 cases, and it showed that they've had a 41% reduction in red cell transfusion, a 47% reduction in plasma, 27% reduction in platelets, and overall they're cost effective. They have saved $80 million in just applying patient blood management protocols. So who benefits from patient blood management? Essentially everybody that forms the healthcare ecosystem will benefit: the professional, the hospital, now the patient is the most important. So these are just some points on why it is beneficial. It improves our clinical outcomes and there's a significant reduction in morbidity and mortality. So how do we apply pediatric clinical practice? So if we take the first look, it speaks about detection and management of anemia. So the questions that we need to ask ourselves as clinical practitioners is, so if you have a 24-year-old patient who has a hemoglobin of 6.5 grams per liter, and the reason for the anemia is hemorrhage, what is the cause of anemia? Is iron deficiency anemia? Is this caused reversible? Yes. Can it be replaced with iron? Yes. Will the patient tolerate the anemia? She's 24 and has no other comorbidities yet. Therefore, this patient does not need a transfusion, even though her hemoglobin is 6.5. On the reverse, if you had a 75-year-old patient who has myelodysplasia, is the cause of this anemia reversible? No. Can it correct it with simple measures? No. Would they tolerate 74-year-old with a hemoglobin of 6.5? Unlikely. So in this patient, we will apply and give a transfusion. The second concept is about minimizing blood loss and optimizing coagulopathy, and this is particularly in surgical patients and in trauma patients. If we claim the use of anticoagulant agents like tranexamic acid, there's a lot of evidence from the fraction trial that if you give tranexamic acid within 3 hours, there's a significant reduction in mortality and morbidity and a reduction in need for transfusion. The women's trials also showed a reduction in blood loss in patients with postpartum hemorrhage, and then many RCTs that have shown the use of tranexamic acid in general and cardiac surgical procedures. The other aspects of this would be surgical technique. If, for instance, they're going to do a liver biopsy, we recommend that it's transjugular rather than percutaneous. We would recommend that the senior person does the procedure if you're expecting a lot of blood loss, and the dating is like used to suffer intraoperative cell salvage. The third pillar is optimization of the patient's ability to tolerate anemia, and this is looking at the patient as a whole. Do they suffer from any chronic illnesses? How we optimize their diabetes, their hypertension, or their cardiac illnesses? If we improve these, and if the patient should run into a position where they need transfusion, then they might be able to better tolerate the brief period of anemia.
Thank you very much, Dr. Next on the agenda, we have Dr. Lauren. Dr. Lauren Wood is a hematologist and medical oncologist, currently practicing at the Port of Spain General Hospital. She's a graduate of the University of the West Indies Tobago campus, and subsequently completed her year at the University of the West Indies Modern campus. She creates present findings of her DNA on the cost of transfusion period of care in myelodysplasia. Please welcome to the podium, Dr. Lauren.
Thank you, Simone. Good morning, everyone, distinguished colleagues, ladies and gentlemen. Today I'm going to present some of my research that I did during my residency in Jamaica, entitled "The Cost and Transfusion Period of Supportive Care in Myelodysplasia Clinical Patients at the University Hospital of the West Indies, a retrospective analysis from 2009 to 2019. All right. So, as we all know, myelodysplasia are hematological malignancies that are characterized by ineffective hematopoiesis, varying degrees of cytopenia, cytogenetic and molecular abnormalities, and variable risk of progression. So acute myeloid leukemia is an uncommon hematological condition, and remains their therapy still supportive care as there's no curative treatment. Many patients will become dependent on their transfusions to manage their symptoms and improve their quality of life. But this treatment is very, very costly, and it requires the utilization of limited medical measures. And it's even been shown to worsen prognosis. So, the National Cancer Institute surveillance of epidemiology and end results database in 2015 to 2019 calculated incidence of myelodysplastic syndrome in the United States to be 4 per 100,000 per year. And globally, this incidence rate is about 0.06, 0.26 per 100,000. And as the population continues to age, we actually expect this incidence rate to be even higher. And it's thought that incidence is less than the cancer registry reports because of underdiagnosis, underreporting, and difficulties in developing durable diagnostic criteria. To date, there are only 4 drugs that have been FDA approved for the use in myelodysplastic related indications, and these are the hypomethylating agent, B15 and D-cyclin, immunomodulatory drug methylomide, and the erythroid maturation agent, luspatercept. But we all know the cost associated with these therapies is a challenge for many, many patients, and most patients who are managed with these still of a transfusion is a major intervention. So why was this study important? Why did I do this study? Well, today there's no similar study of MDS in Jamaica, in Trinidad, or even wider Caribbean. And determining the transfusion burden can actually be beneficial in making resource allocation, planning management strategies, particularly in the face of significant shortages of blood supply. Particularly significant shortages of blood supply locally, and treatment decisions can be altered by comparing cost-benefit analysis between supported care transfusions and these targeted therapies for MDS. So this was a retrospective census of patients with myelodysplastic syndrome who started at Penn Hematology Clinic at University Hospital of the West Indies between January 2009 and December 2019. Eligible patients were male and female, and they were ages 18 years or older, and they had a confirmed diagnosis of myelodysplastic syndrome. All patients, as we said, were newly registered at the clinic between January 1, 2009 and December 31, 2019. And the patients were excluded if they were already on medication that were approved for myelodysplastic syndrome. So the sample size was estimated to be 88. Transfusion dependence was defined based on the International Working Group 2006 criteria as greater than or equal to 2 red cell units over an 8-week period. The cost of the transfusion was calculated using the procurement prices from the billing department at the University Hospital of the West Indies 2020. Transfusion burden was further broken down based on the International Working Group 2018 criteria. So patients were described as being non-transfused if they received no units within a 16-week period. Low transfusion burden if they had 3 to 7 units within a 16-week period, and a high transfusion burden if they had baseline equal to 8 units in a 16-week period. So the primary endpoint of the study to identify the incidence of myelodysplastic syndrome at the Hemong clinic at UHWI, determine the transfusion burden of the supported care treatments of patients with MDS at UHWI, and to determine the cost of the transfusion dependence in the first year of diagnosis of MDS. And as a secondary endpoint, look at the most common transfusion-related adverse events in the MDS population at UHWI. So now we're going to look at the little bit. So a total number of 31 records were reviewed for the patients who were registered as new patients at the Hemong clinic between January 1, 2009 and 31, 2019. Of these 31 patients, 7 were excluded because they did not have a diagnosis of MDS. 1 patient was excluded because they were previously diagnosed with MDS and was treated. No patients were on medications that were approved for use in MDS. With 3,544 new patients in the Hemong clinic study. And this gave an incidence of MDS in these patients of around 0.6. So in terms of the patient demographics, so we see in this table that the study included both male and female patients, but there was a slight male predominant in the study, with about 56.5% of the patients, about 43% being female. Patients were between the ages of and 94 years of age, with a mean age of about 73 years. And most of the population was between the ages of 70 to 79. And about half of the patients were over the age of 60. Very small percentage of the patients were younger than 60 years of age. So this schematic looks at the transfusion requirements. If we look at the one on the left, you see that 86% of the population was classified as transfusion dependent, and that's the bar that's in blue. And there was an even gender distribution between male and female. And in terms of the transfusion independent cohort, we saw that all of these patients were actually male. Transfusion dependence was seen mainly in patients who were over the age of 70, that's in the graph on the right. And all transfusion independent patients 60 and 80. So in terms of the transfusion burden, cohort of patients who need to be transfusion dependent, they had a higher transfusion burden as defined by the study definition than those with a low transfusion burden. So we see about the graph in blue, much greater than in the orange. All right, patients older than the age of 70 years of age received more than twice the number of transfusions on average than those who were between the ages of 50 to 69 years. So we see a portion of the pie chart in gray, those are our patients between the age of 70 to 79. So in terms of hospitalization, MDS transfusion dependent patients, they were 2.5 times more likely to be hospitalized compared with their transfusion independent patients. And the reason for admission varied. It could have been because of symptomatic anemia, infections as a result of their cytopenia, and there were some admissions that were totally unrelated to MDS, things like unstable angina, diabetic emergencies. Also, some of the complications of transfusion. So transfusions were complicated. Only 3 out of 20 patients, and it remained uncomplicated in 17 patients. Patients with complicated transfusions experienced mainly febrile non-ballistic transfusion reactions or allergic transfusion reactions, and they subsequently required pre-medications for any further transfusions. 5% of the patients had TACO, but luckily for us, no patients in this study had significant thrombolytic transfusion reactions or TRAL. So now let's look at the cost. So in this table, the figures that are black are actually quoted in Jamaican dollars, red, US dollars. So as we can see in column 1, transfusion dependence was the principal driver of cost amongst the patients in this study. So the total calculated mean cost incurred by transfusion dependent patients in a 1-year period was about $1,300 US. And this was particularly significant when compared to the transfusion independent cohort with a cost difference of about $960. The transfusion dependent patient also spent an average a larger statistically significant proportion of money on group and cross-match testing, as well as red cell transfusions and their transfusion independent counterparts. But the average cost difference in terms of CT testing was not statistically different between the two cohorts. So there were many, many important challenges when doing this research. One of the most limiting was data collection. So docket retrieval was difficult as dockets that were deemed inactive for 7 years or more were actually purged. A number of dockets were signed out of the department and were not returned. Due to lack of documentation and coding errors at the medical library as well, it was possible that the true incidence of MDS was underestimated. And there's a poor understanding, as we said before, of the disease and the evolving diagnostic criteria. And this has also resulted in underdiagnosis, misdiagnosis of MDS by physicians, further contributing to the very low incidence rate. Another major challenge was unavailability of blood products. So there's a great discrepancy that exists between blood supply and demand in Jamaica, in Trinidad, and I'm sure even in the wider Caribbean. And this is really due to a lot of taboos and a lot of myths that we spoke about yesterday about blood transfusions. And in this transfusion dependent study cohort, they were actually inadequately transfused because of blood shortage. Given the lack of the blood product we had in Jamaica, the transfusion burden was probably well underestimated in this population. We also underestimated economic burden, so we did not take into account all the services that were offered. So admissions to the hospital, presentations to the ER, visits to the outpatient department, the actual processing of the unit, so filtering of the red cell units, patient required red cell antibody testing and extended cross-matching. If they have to purchase pre-medication because of adverse transfusion reaction, and there are other pharmacy fees that we didn't consider, so patients have to get antibiotics if they were on analgesia, or if they have to take medication because of some complication that they developed from their transfusions. And another, to me, very important limitation that we did not look at was the impact on quality of life. So patients spend a lot of time traveling to and from transfusion centers, the time that they spend actually being transfused, and that wasn't considered. And this can have a great impact on their social life, their work life, it can lead to unemployment, it can lead to feelings of abandonment, reduced goals in their home and so on. And I think this is something that should have been explored. All right, so just to discuss some of the results a little further. So as we said, the incidence of MDS was found to be higher in this study, 0.6, compared with cancer registry reports in the US, and even in the wider world. And as we said before, it was probably because of the underdiagnosis and misdiagnosis. Most patients in this study were more than 70 years of age, which is in keeping with data from the NCI-SDR database, 2001 to 2019, where 85% of the MDS cases were diagnosed below 60 years of age. Additionally, the NCI reported a significantly higher incidence rate in men than women, and this was in keeping with the findings of this study. In this study, 80% of patients were found to be transfusion dependent, but the number of units that patients transfused was only 3. And this is really not in keeping with international data from a study published by Gupta et al. They found that 80% of patients with MDS required a transfusion. But of these patients, the mean number of red cell units transfused was about 8. So this really again reflects our blood supply shortage. Another study published in Blood in 2019 looked at the transfusion burden among United States patients newly diagnosed MDS. And they actually found that 21% of patients had a low to moderate transfusion burden, 0.2% had a high transfusion burden, and 78% had were deemed transfusion independent. And this is very different from this study that we did, where only 48% of the patients had high transfusion burden. Only a small amount of patients were deemed transfusion dependent. So we can see really that a lot of our patients were still relying heavily on the transfusion for management. In this study, the transfusion-dependent cohort patients had a higher mean annual healthcare cost, as we saw, 1,800 compared to the transfusion-independent patients. And in a study by Felicitas et al., they estimated the annual average cost of transfusion dependence in the Nigerian population to be a whopping US $17,410. So very different from what we got in this study. Not surprisingly, though, group and cross-match and packed red cell units comprise bulk of the cost of the patients in this study. But if we look at the cost of a unit of blood in this study, it was only US $20, and there's a great disparity of about 90% in what the average cost of a unit of tax in US is about $343, and there are various possibilities for this. One is that all of the costs are not transferred to the patient, so some of the costs are actually burdened by institution. So what I want to say, while appreciable, the cost of supportive care is very minimal when compared to that medications approved for use in MDS. We can range anywhere from about $7,000 US dollars to $150,000 US dollars. So we see a lot of our patients still looking to transfusion of support. So in conclusion, transfusion dependence is an economic burden. The cost of supportive care medications that newly were found to be 4 times greater than in transfusion independent patients, with previous studies. About half the patients who receive red cell transfusion have high transfusion burden, but the mean number of units transfusion less than studies, reflecting an issue of blood product shortage. And despite significant healthcare costs of transfusion dependent supported care still really comparatively cheaper than. Thank you.
Thank you, Dr. Bruno. Unfortunately, Dr. Levi is unwell and is unable to present today. So next on the agenda, you have Dr. Mohammed Rahman. Dr. Mohammed Rahman completed his undergraduate training at the University of the West and his internship at the Port of Spain General Hospital. He completed his membership to the Royal College of Physicians before pursuing an adult gastroenterology fellowship at McMaster University in Hamilton, Ontario, Canada. He returned to Trinidad in 2018 and has since been a consultant gastroenterologist and head of endoscopy at the Port of Spain General Hospital. He also practices privately. He is an associate lecturer with the University of the West Indies, past president of the Tobago Medical Association, and the current secretary of the Gastroenterology Association of Trinidad and Tobago. He will review the management of GI hemorrhage. Please welcome to the podium, Dr. Rahman.
Thanks, Charles, specially invited guests, all of the formalities observed. Good morning, everyone. Thank you very much for the very kind introduction, Simon. And today we'll be discussing gastrointestinal hemorrhage. Now, in reality, this topic could easily be 3 separate 1-hour talks, so I've tried to group things together so that we can proceed and not stay here until this evening. These are my disclosures. So just an outline of today's presentation, we're going to be chatting about common management principles of GI hemorrhage, non-variceal upper GI bleeds, variceal upper GI bleeds, and lower GI bleeds. We'll be separating patients into those who are stable, those who are unstable in the specific management, some key management points, some guidelines, as well as some takeaway messages. So we're going to start off with a pre-test, and we're going to read the stem. A 51-year-old male presents at 2 a.m. with a history of 2 days of loose spleen and weakness. He's hypotensive and tachycardic. What is your next step? So let's have the option. Discharge an oral PPI immediately. Call on call GI immediately for scope right now at 2 a.m. Fluid resuscitate, start IV PPI, then PPI infusion, then admit for endoscopy. Or the same with blood instead of crystalloids. Or E, give orders to admit, still call GI right away at 2 a.m. and wait to scope the next day. So remember the answers for that. I'm going to take the same step. Next question. This patient has responded to IV fluids. He's now normotensive, but no IV PPIs are available. So the last question. So what's the next best option? 1, oral omeprazole. 2, IV ranitidine. Oral sucralfate, oral misoprostol, or give what admits equal GI right away at 2 a.m. So these are some common causes of GI bleeding as separated by different anatomical locations. It's important to remember upper endoscopy can go down to the proximal duodenum. We can identify sources of bleeding there. A colonoscopy can go to the distal terminal ileum, the last 15 to 20 centimeters. But that area in between is very hard to identify the source of bleeding, or challenging. And also some of these causes we're not going to be addressing today, like hemorrhoids and infections. Something to bear in mind as you proceed. Upper GI bleeds can either be variceal, that is bleeding from esophageal varices, or non-variceal. Peptic ulcer disease or peptic ulcer bleeding accounts for between 1/3 and 2/3 of all non-variceal upper GI bleeds. Remaining are all other non-variceal GI bleed causes. There's excellent evidence for the management of peptic ulcer bleeding. Not so much for non-peptic ulcer bleeding. So how does a GI bleed present? It may be hematemesis, frank red hematemesis, or coffee ground emesis. It's important to remember this coffee ground emesis, when it occurs by itself, suggests a very small body of blood, maybe about less than 50 ml. If the patient presents with melena as well, that's a significant amount of blood. So melena suggests there was more than 50 ml bleeding. Of course, the patient may present with frank red blood per rectum or maroon blood per rectum. A reminder, maroon blood is not melena. Melena is black, like soft serve ice cream, like you see on the picture. So frank red blood hematochezia usually portends or suggest that the source was a lower GI source, but it can represent massive upper GI bleed. Such patients present either with overt hypertension or orthostatic hypertension, perhaps a history of loss of consciousness. The majority of patients who have an upper GI bleed, non-varicose, actually don't die from exsanguination. They die from an exacerbation of pre-existing medical illnesses. Concurrent major diseases need to be identified and managed, treating wherever appropriate as they may worsen with the bleed. So, for example, an MI, ischemic heart disease, worsening heart failure, etc. Common management principles when a patient is bleeding, whether it's hematemesis, whether it's hematochezia, or GI bleed. First of all, decide are they unstable. If they are, they need to be resuscitated. While resuscitative efforts are going on, we want to take a focused history and examination to help identify what is the etiology of bleed. We do some baseline investigations and we will stratify the patient based on their risks. We're going to come to some scoring systems very shortly. We want to localize the source of bleeding, definitively stop that bleeding, achieve definitive hemostasis, treat any underlying disorders, and prevent recurrence of the bleeding or advise the patient on when they need to come back to the hospital. Is the patient stable or unstable? This helps us to determine the need for resuscitation, where the patient is going to be home, is going to be discharged, and more to the HCU or the ICU, what level of monitoring is needed. It also helps us to determine the timing of endoscopy. For lower GI bleeds, whether the patient is stable or unstable will help us determine whether or not they need an upper endoscopy in addition to the lower. So of course you're going to take vital signs, take screen examination, 2 large bore accesses to be able to gain intravascular access to get fluids, baseline blood investigation, key ones are TBC, the function test, PT, BTT, INL, depending on the situation, the patient may require the cross match as well. The creatinine ratio can be very helpful. Input output charting. And does this patient need a blood transfusion? We're going to come to the points just now. Target 7 grams per deciliter or 7 grams per liter. In the event of an upper GI bleed, that is one that presents with melena, frank hematemesis, or unstable hematochezia. This patient needs to be kept NPO because when we do the comprehensive research, we don't want them to aspirate. There's some suggestion of an NG tube, but this can give a false sense of security. If an NG tube goes into the stomach, it can only identify frank blood in the gastric lumen. Any bleeding distal to the pylorus may be missed, and I've seen at least one case where NG tube was passed, the surgeon had great confidence there was no upper GI bleed, performed a colectomy, and the patient relapsed. If the patient has an altered status, consider whether intubated to protect that airway, and PPI is a cornerstone of management of GI bleeding, infusion or intermittent dosing. And if IV isn't available, use PO. The unstable patients, hypertensive, tachycardic, they may have altered mental status, history of loss of consciousness, or ongoing. Such patients need to be resuscitated. It's important to give repeated boluses until the blood pressure and pulse respond. Sometimes I see people give one bolus and say what they thought and they didn't respond. That's not appropriate. Watch out when you're giving IV fluids if you're going to provoke a fluid state, particularly in patients with congestive cardiac failure or advanced renal disease. Patients who are stable or who had been stable and then became resuscitated, particularly stable patient or patients that appear to be very stable, it's important to get a standing and lying pressure. And this is a very sensitive indicator of hypertension. When the patient presents to the emergency department, to repeat CBCs up 4 hours after the first one, this helps determine if there was a significant drop in hemoglobin. I'm going to segue into if there is a suspicion for varicose hemorrhage, that is, if this patient has a known history of cirrhosis or history of varices, for example, if you don't use thrombocytopenia elevated by the lung, consider could this be a varicose bleeding type? Clinical picture needs to be taken into consideration. And if there is a significant chance that this is a varicose bleed, we need to additionally give antibiotics essential, not something that people think about, perhaps the most commonly important element of the bleeding. We need something to cause clamping, vasoconstriction, increase the blood supply to the varices so the bleeding decreases. We can either use octreotide by infusion or intermittent antidepressant. In this case, an urgent endoscopy needs to be arranged within 12 hours by a gastroenterologist trained in the management of varices bleeds. Popping in a scope and identifying the varices without being able to be less. For an unstable upper GI bleed, these are all comers upper GI bleeds. We should aim to resuscitate the patient first and then get an endoscopy within 24 hours for these unstable patients. However, a recent study published by Lau et al. In 2020 suggested that if this is done within the first 6 hours, it's actually an increased rate of adverse outcomes. So within the first 24 hours, after they've been stabilized and avoid doing going to lower GI bleeds. Now, if the patient has high risk clinical features, going bleeding, give a bowel purge. Well, first you resuscitate, then you do a full bowel preparation. And we aim to do a colonoscopy within 24 hours of resuscitation. This is to identify the source of bleeding and be able to intervene if it's something that we can intervene on. And of course, a colonoscopy should be the initial diagnostic procedure for all patients with GI, and perhaps not a prophylactic prevention. Surgical consultation, high risk in patients with high risk clinical features and ongoing bleeding is vital to be done. You get them involved, but the surgery itself must be done only after all the it is vital to localize the source of the bleeding before the surgery is done to avoid an inappropriate resection that misses the culprit. So, if the patient has had negative upper endoscopy, they still have high-risk clinical features, ongoing bleeding, and if they haven't responded well to resuscitation, and that would suggest that they wouldn't respond well to bowel preparation, urge to be able to work with it. In this event, intervention radiology would be assistance to identify the source of bleeding by angiography, and then to apply embolization onto it and sentence if it's available. Everybody knows this. Stable GI bleeds, like blood pressure, pulse is normal. So how do you decide when a patient is stable? It's appropriate to discharge them or not? We're going to look at two scoring systems, one for upper and lower GI bleeds. We get the Glasgow Blatchford score for upper GI bleeds, and if the patient has a score of 0 or 1, it suggests that they have very low risk of rebleeding and a low risk of mortality. They may not require hospitalization, and they may be discharged if not requiring a patient endoscopy. The scores for the GBS can go between 0 and 23. Higher scores suggest increasing acuity and increased risk of mortality. Scores greater than 1, however, do not necessarily mean that the patient needs to be admitted right away. We can all imagine that score on the right-hand side of the screen, a patient with stable beta thalassemia or sickle cell disease who had twice they would score very high on that scale. So this has to be taken with a pinch of salt. Just a few points, coffee ground emesis is not on this score. Because as we said in the first few slides, coffee ground emesis suggests that the volume of bleeding was less than 50 ml, a very small amount. That's not a high risk free here, unless there's melina as well. Melina is here. A mild elevation in the liver enzymes, mild transaminitis, so mild hepatic steatosis, not liver disease, don't count it as that. If somebody's having an echocardiogram, it's estimated diastolic dysfunction. That wasn't heart failure when this was not counted. And the analog in the lower GI bleeds, the Oakland score. The Oakland score helps to decide if safe discharge is possible. A safe discharge is defined as absence of free bleeding, blood transfusion, therapeutic intervention, 28-day readmission, or death. Scores less than 8 suggest that this patient can be safely discharged with appropriate precautions and advise them on when to go back into the hospital. And scores greater than 8 suggest that perhaps admission is indicated for this patient. And of course, if they have resuscitate. There's a little bit of score on the right side. So we have the Glasgow Blatchford score for the GI bleeds, the Oakland score for the GI bleeds. They're all available. One search away on. If the patient has no high-risk clinical features, again, we're talking about a low GI here, no serious comorbidities, or they have a serious comorbidity or high-risk clinical features, but no evidence of ongoing bleeding, this can be performed next to fatal. So if the patient has a GBS score of less than 1 less than, or Oakland score for the lower GI bleeds less than 8, and this patient can go, ask yourself if there are any other reasons that this patient needs to be admitted to hospital care or treatment. And in the event that the patient check the static pressures, no change, the hemoglobin, bleeding, make sure to stop all NSAIDs or aspirin. Aspirin, if it's given for primary prevention, just stop if it's a secondary prevention. Talk to the cardiologist as well. In the event of a stable, simple upper GI bleed, it can be discharged. They should be discharged on PPIs and consider the GI referral. Now we're going to go on to the point of the non-varicose upper GI bleeds and lower GI bleeds. Numerous guidelines here, we're looking at North American guidelines mainly, and some international consensus recommendations. And we're looking at one lower GI bleed guidelines from the American. So non-varicose upper GI bleeds, one paper in 2019 from the international consensus group suggested a target threshold transfusion of 8. But then about 40% to 50% of those study authors were also involved in the development of the ACG guidelines. And the ACG guidelines, which was developed in 2020, developed and published in 2021, actually suggested a threshold again of 7 grams per deciliter. This is data. So the most recent guidelines are used to suggest transfusion threshold 7, unless there's ongoing bleeding or major comorbidity, in which case we can target the 7. So Professor Robert Tudor has spoken about meta-analysis of trials that show that particularly in GI bleeds that a restrictive transfusion policy is superior to a liberal one. And I decided to summarize a study, a landmark study that I have. One of these studies in the medical papers, but those are very important. 900 patients randomized 1-to-1 with a liberal transfusion strategy or restrictive. What that meant, if you're in the restrictive transfusion strategy, this is all comers of the GI, varicose and non-varicose. If you had a bleed, your hemoglobin fell below 7 in the restrictive group, that was your trigger to get blood. In the liberal group, it fell below 9, that was the trigger to get blood. And look at this, in the restrictive group, there was improved outcomes in every parameter stable. So look at the left, more blood transfusion than the liberal, obviously higher mortality, further bleeding adverse events, higher mortality in varicose bleeds in patients with child Q, A, and B. In child C, it didn't make a difference. Very significant. Portal venous pressures were increased with the liberal transfusion strategy. Varicose rebleeding was twice as high, and death due to unsuccessfully controlled bleeding was more than 3 times higher in the liberal transfusion. This really goes against what would have brought about in medical school. Restrictive transfusions in the context of these GI bleeds is beneficial. And the professor also spoke about the seminal trick trial done in 1999, transfusion requirements in critical care, that had first suggested that a restrictive strategy was superior. So we should all be looking at the 7 as a trigger for blood transfusion as a threshold. Lower GI bleed guidelines also suggest a threshold of 8 and slightly higher, again, if ongoing bleeding or significant comorbidity. Going back to upper GI bleeds, non-varicose upper GI bleeds, suggests the patient is on anticoagulants. With the patient is on anticoagulants, that should not delay upper endoscopy. So if the patient is on warfarin or the patient is on DUA, we should still go in to do the endoscopy whether or not we can achieve hemostasis. And that's to help identify the lesion and utilize it. In separate studies, we found that correcting or aggressively correcting an INR down to 5 below 8 led to mortality further fewer ischemic events. And another study from 2011 had suggested, in the context of a non-RSF that an INR at presentation greater than 1.5 is associated with mortality, but interestingly, not rebleeding. Back to the lower GIB guidelines, it suggested go ahead and do the bowel purge and the colonoscopy if the INR is between 1.5 and 2.5, proceed. But if it's greater than 1.5, maybe we should correct that first. And the discussion as to what we use to correct that is definitely beyond the scope of what we have time for today. Lower GI bleeds. If the patient is thrombocytopenic and bleeding, give platelets. If they're thrombocytopenic and not bleeding, give platelets, and that's something that principle is constant through the GI bleeds. And they also suggest platelet and plasma transfusion to those who receive massive red cell transfusions, but they give no guidance on pre-endoscopic PPIs. So why do we give PPIs? Yes, they encourage this. Remember, we mentioned that PPIs are the cornerstone in the management of the GI bleeds. PPIs do improve mucosal healing, but more importantly, they decrease the gastric pH. They increase the gastric luminal pH, blocking the acid and the acid production. The reason for that is because gastric acid and pepsin inhibit clot formation and promote clot lysis. So hemostasis is inherently defective in the gastric luminal. So PPIs are known to downstage the gastric lesion, and what we mean by downstage, we're talking about first classification ulcers. And we see score of 1A as the highest risk of bleeding, so that to be squirting vessel in an ulcer, and all the way down to 3, we have a clean base ulcer with a very low risk of bleeding. In fact, a Forest 3 ulcer identified with endoscopy, that patient can be discharged right away. But giving PPIs can drop this stage or downgrade an ulcer. So you might go, for example, from a 1B to a 2A, or 2A to a 2B, and so forth. But giving PPIs should not be when the studies were assessing PPIs, and this is important, it made no difference whether the control was a placebo or ranitidine. Whether they used ranitidine or sugar water, it made no difference in the outcomes. Therefore, ranitidine is not indicated in the management. IV ranitidine is not indicated. Regimens that were assessed however included oral PPIs. Going back to that same previous question in your on, you remember what your answer was? And the second previous question, I think for the GI 2 AM, but oral PPIs. Endoscopic therapy suggested by the societies include bipolar coagulation, absolute ethanol, CLIPS, argon plasma coagulation, or soft monopolar electric coagulation. APC, argon plasma coagulation, is available at one hospital in last 4 months. The other things, however, are available. On the picture on the left, you can see an Forest 2A ulcer, the incisura with a visible vessel. And I'm just putting a clip onto it. Now sit on, sit back down, give me 30 seconds. Don't stand this on. First, the picture on the right, you can see the clip applied to the vessel that was successfully controlled. And the next slide, you can see the scrutiny vessel on the left and on the right hand side of the screen. You see a bipolar probe used for hemostasis endoscopically. Take home messages from the non-varicella progenitors are such a long tablet. Moving on to the last few slides, varicella progenitors, similar target, hemoglobin of 7 to transfusion. Platelets only if they're actively bleeding less than 50. Antibiotic prophylaxis is mandatory for all patients with cirrhosis and the GI hemorrhage. Antibiotics are recommended for all patients. EGD should be performed within 12 hours with suspicion of a varicella bleed, and often endoscopy to unstable patients with severe bleeding immediately after resuscitation. So patient with known cirrhosis comes in massive hematemesis, hypotensive, as you're resuscitating them. I don't care if it's 2 o'clock in the morning, that's when they give me the intervention for varicella bleeds, upper endoscopy and endoscopic varicella ligation. This is what we do in principle. These are some pictures of what we've actually done. On the top left-hand side, you can see engorged esophageal varices, and you can see right here from where it just stopped bleeding. So we're able to identify this area with a band on it. On the retroflex view, you can actually see a gastric varix on retroflexion, and we're able to band that over usually after use. Final post questions here. Which of the following pharmacological interventions reduce mortality in variceal bleeds? Any takers? Any takers? None. None have been shown to do that. Which of the following pharmacological interventions reduce rebleeding in patients with a variceal bleed? Come on, anybody? Simon, what do you think? Octreotide, says octreotide. Anybody else? Anissa, what do you say? Give me one, guess one. Says B, octreotide. Anybody think that's octreotide? I thought so too. No. Prophylactic antibiotics reduce rebleeding, and nothing else has been shown. Takeaway messages from variceal bleed: resuscitate, antibiotic prophylaxis, octreotide or telepressin, endoscopic variceal ligation by something. And afterwards, you can put on some beta blockers and put on more bands at the later stage. Everyone, thank you very much for your time.
Okay, so now we have our question and answer period. Anyone else can bring any question? Anyone else? Dr. Rama. What's the point of giving the octreotide then? It was still a minute.
You should get it back up your class, choose an answer. So octreotide and as well as telepressin decrease planting, they cause planting vasoconstriction. Remember that this is where the blood comes from that feeds the esophageal varices. So we're decreasing the planting flow and decreasing the bleeding actively. Now, what they're talking about here is statistically reduce bleeding when we take all comers in our population. Presumably, if a study is done looking at very specific people. But I'm putting the data right now, it doesn't reduce rebleeding. It may increase the chances of achieving a hemostasis of the index endoscopy.
All right, then, anyone else? Any more questions? Speak now, speak now. We have, there's one on my phone. I need to. Okay, so Dr. Goody is first. Right, so Dr. Keith Wilson, would like to know, do you have a facility to do genetic tests on your patients with NDS to further define their risk factor?
Thank you, Dr. Wilson, for the question. In Tobago, that facility is not available. Patients have to access it at the private lab and the samples go out. Very few of them.
Anyone else? Okay, hold on, I'm coming. Just one question. I don't know if I missed it in your presentation. You compared the incidence of myelodysplastic syndrome to the international standard, and you also compared the use of the blood product. Did you ever compare or answer whether they use less blood product because a lot of the patients were able to access the medication to choose it? Because from it, I don't think anybody had that.
No. So unfortunately, as we find a lot of patients who can't afford the MDS targeted therapy, so would be like heavily on transfusion. Even though our burden wasn't that high, it really was because a lot of patients who needed a transfusion couldn't actually get one because of the unavailable.
So everyone, please get ready. Dr. Charles has a question for each of you. So we'll start with Dr. Budi. She already has them.
I try to remember all the questions. You know, they ask, you know, population.
Is that the kind of classification?
Yeah, maybe it's the population. And did you study reports?
Non-indications in this study actually work with races. We do use it, there are provisions on it, but in terms of this study and this population, we saw after 2019 maybe 1 or 2 patients on it.
With this problem. Create any difference. Right. So yeah, Dr. Friday measure patient blood money.
Difficult is the appropriate use of blood companies. As we said, it is a scarce commodity, so we have responsibility to use that.
Right. Which was the most
To me, I think the most important commandment is actually the medical education, the ongoing medical education and clinicians and nurses, all of that. This is how we continuously improve our services.
It's be important.
Sorry, say again.
So it appears to me you do what you have to do. Somebody,
That's right. Correct. You do what you have to do. So in terms of identifying the source of pain, I think the endoscopy doesn't really. There's a lot of support.
yeah, because and the second thing, I don't know how many times they would come. Good, because I mean, they would they come so
So this is so today's presentation was mostly about acute bleeding, and really I limited the discussion to that. But certainly there are patients that present with subacute bleeding. So for example, rectal bleeding has been going on for the last few months, and in the context of inpatient we have the in terms of bleeding, the patient that has a weird upper GI bleed usually have an upper endoscopy. And based on risk factors, we decide whether or not they warrant to have a endoscopy. Generally, if there's if the history and examination point start with and the decision.
Anyone who has anything burning? No. So by a show of hands, who wants to take a break now? Okay, so Dr. Captain, I'm going to answer. Okay. Dr. Kavi Capoleo is a hematologist and medical oncologist at the Brian Lara Cancer Center and a medical associate hospital and an associate lecturer at the Faculty of Medical Science, University of the West Indies since 2000. He was trained in general medicine at Queen Elizabeth Hospital, Gateshead, and continued in hematology and oncology at the University Hospital of West Indies, and as a registrar to Dr. Wade Richard at the General Hospital of Port Spain. He obtained a specialty certificate in medical oncology from the Royal College of Physicians in 2010, with ESMO certification in 2009, and was recertified in 2014 and 2014 and 2008. He served as a consultant at the General Hospital of Port of Spain and the National Remunerated St. James, and as the founding department head at the Oncology Department, San Grande Hospital. He's a member of the Board of Directors of the Trinidad and Tobago Cancer Society and the Palliative Care Society of Trinidad and Tobago. He's here to speak to us about blood product use in oncology. Please welcome Dr.
Well, thanks very much for the introduction. And I have to say that there's a lot I don't have to cover because of the previous presenters, especially Dr. Friday going to patient blood management, which applies to patients with cancer and everyone else. Just brief disclaimer, I'm not going to cover pediatric hematology here. That's a full topic in itself. I'm not a pediatric hematologist. And secondly, the use of blood products in stem cell transplantation, plus the practice of stem cell transplantation is something we don't do in Trinidad, to what the program. Yeah, we already know that cancer is common in Trinidad, breast, prostate, being top of the list, along with colorectal and lung. And since we've been looking at our blood services in a system where the government runs a public system of healthcare that's free at the point of delivery and funded from general taxation, as is the British NHS, we have been looking at the English and Welsh examples several times. And so just to compare briefly what our cancer situation was that UK is. And with mortality here, you can see a lot more breast, a lot more prostate mortality in our population. So when you're looking at the whole issue of cancer control nationally, cancer treatment is just one area, a very important area, but still have all the matters of prevention, diagnosis, staging and screening. Some people are cured but have issues in the prevention stage. Others require palliative care. And then you have the whole issue of delivering services, governance, workforce, and so forth. But moving on to treatment, because that's very critical. Finding those boxes there and a blood draw icon displaying here. But just showing you that in all the various scenarios and all the various modalities of cancer treatment, which is typically multidisciplinary, you can see that blood product support may be required in nearly all of them. Surgery, radiation, chemotherapy, immunotherapy, and targeted therapies, and also in the supportive setting. And this is a rather busy slide, and you're all familiar with this, so I don't need to go through it in fine detail. But just to show that anemia is common in people with cancer for a whole host of reasons. Both related to the tumor itself, for example, right? Just listening to Dr. Rahman about bleeding from GI tumors, also bleeding from cancer of the kidney, bladder, etc. It might be infiltrated by metastases, or maybe a primary site disease, leukemia. And of course, anemia of chronic disorders mediated by cytokines. Less commonly, you may have background hemolysis, association with metastatic carcinoma, also as a complication of some drugs, and autoimmune hemolytic anemia may be paraneoplastic syndrome in some cancers, less commonly red cell aplasia and xenothymoma, and of course cancer treatment. And this is not to say that the treatment is any worse than disease or any such, but it can be challenging. And chemotherapy and radiation can sometimes actually cause bleeding, for example, by causing myelosuppression and thrombocytopenia, or for example, hemorrhagic cystitis from cyclophosphamide or from radiotherapy. And of course, if your radiation fields cover a significant amount of hematopoietic marrow, for example, if you're radiating the spine or the pelvis, then you can get myelosuppression impacting your red cell production and your platelet production. So, red cell transfusion, largely about the same principle that we looked at in the previous talks. So, the UK guideline do point out there the transfusion threshold isn't really well defined. People are the sector of chemo. Not much in the way of randomized controlled trials there, but most units in the UK try to maintain hemoglobins above 8 or 9 in that setting. Just to be aware, it's single unit transfusion given. Decades ago, there was some rule of thumb about if a patient needs any given two, there's no evidence for that. If somebody's just anemic enough to need a transfusion and one unit gets them to where it will need one. And also to be aware, if the voices stimulating agents are preferred more in the palliative setting, for instance, come to just now, it can be used to reduce the transfusion requirements. Also, correction of iron deficiency, was to be aware of B12 deficiency, for example, if your patients had tibia in a resection because they had a red cell full of cancer years ago. Consider IV iron, low ferritin, or if you've got low saturation of ferritin, 500, control of bleeding, sometimes radiation is useful for this, stop bleeding from a tumor. And also not doing unnecessary spot piece. And coming back to your erythropoietin therapy, consider this for hemoglobins under 10, if palliation is the goal, and ferritins under 100, you should give IV iron with it. And it can have an increased bone mortality, and some tumors do have receptor for erythropoietin with some risk of triggering growth, so it's more preferred in the palliative setting rather than the curative setting. Now, one area of controversy we've had over the years is about radiotherapy and the transfusion threshold. But if we go back to our radiobiology, we know that radiation kills cells, including cancer cells, by causing double-stranded breaks in DNA. And while some of this is from direct action of interaction with the photon to the double helix of DNA, most of it is from indirect action with interaction of, instant photons will cause injection of an electron from part of tissue. And those electrons can either directly hit the DNA double helix and cause strand break, or more often interact with the water molecule, causing formation of reactive oxygen species and radicals, and better oxidation to the tumor could, in theory, and sometimes supported, promote that process. So there is that concern as to whether hypoxia in the tumor promotes radioresistance, and also whether anemia can promote tumor hypoxia. So historically, 10 was often used as a figure to aim for in blood radiation. However, that's not particularly backed by much evidence. There isn't much in the way of randomized evidence here, though. There's one Danish study looking at head and neck cancer, which used fairly high triggers for transfusion, 13.5 to 14, but that study showed no benefit to transfusion. More recent study published in BJC showed no decrease in tumor hypoxia in head and neck squamous cell cancer with packed red cell transfusions. So generally the same target of trying to maintain 819 is often sufficient. And an important thing to point out, because of this so-called rule of thumb about keeping it 10 over 10, there's a practice that I have to point out and raise some concern over. That is that sometimes when people are on radiotherapy and the hemoglobin dips to 9.99 or whatever, sometimes the practice to stop the radiation and hold off for a while they send people out to get their chits and get blood transfusions. And the thing is, not that hemoglobin, when it's not that radiation kills you if hemoglobin is 9.99, is that 10 was some kind of rule of thumb because maybe a better hemoglobin gives you better oxygenation and better resensitivity. Well, that's not proven in practice, but splitting your course substantially reduces the effectiveness. So you're basically cutting off your nose to your face if you have patients with a little bit anemic and you split their course. It's not to be done. It's just a review that you can check on, showing that basically no very clear evidence that there's a transfusion threshold to stick with. Or just this came out last week from the Royal College of Radiologists Association of Cancer, UK, looking at how to approach blood transfusion in oncology when red blood cell stocks are low. So this is probably applicable to us all the time. So basically sticking with the NICE transfusion guideline 2015, aiming for restrictive transfusion thresholds in death of major hemorrhage or acute coronary syndromes, and considering a threshold of 7, target of 7 to 9 hemoglobin. I know in the UK, grams per liter has been 70 to 90. And again, it consists of single unit transfusions when not suffice. If systemic therapy ongoing, consider other measures like IV iron, ESAs, and consider less mild therapy or palliative intent. Via local protocols for red cell transfusions, consider chronic blood cancers, and unless an emergency, if you're wondering somebody might need blood or not, you're a house officer or intern, discuss with the senior rather than just ordering blood. So, thrombocytopenia, fairly common for therapeutic depression, sometimes with power involvement. Less commonly, secondary ITP, and you can have situations with DIC and TTSHBT cancer. One thing to point out that as people who don't have cancer, conditions where you have consumption of platelets like ITP, you will only receive platelet transfusion for life-threatening hemorrhage regardless of number. At the ASCO guideline, basically prophylactic products, prophylactic transfusion platelets less than 10 and you're undergoing chemo. Consider a higher target like 20 if they have ongoing hemorrhage, sepsis, coagulation abnormalities. This one's in the US but not the UK guidelines, which could be possibly controversial, rapidly falling platelet count. And that sometimes is a question if you're in local setting. If your patient's platelets have gone down from 16 to 11 over the course of a day, and your local hospital can spare you 3 units of platelets or 4, and they're expiring at midnight, what do you do? But as you know, trigger 54 basic procedures and marrow biopsies, provided there's no coagulation problem, you don't need to give platelets, just as pressure afterwards. If you've been cryo, similar indications to general medicine, we can there, but just to point out that you use those to correct bleeding, not to correct numbers. And there was a bit of oncology and pediatrics, some indications for irradiated blood, and it's possible to irradiate blood with linear accelerator. Those who are involved in that can look into it later. Just briefly mentioning that anti-CD38 antibodies for myeloma create their own challenges with cross-matching because it was false positive. There are improved tests, and that could be an issue with your cross-match. Therapeutic apheresis can be useful with the kind of viscosity paraproteinemias and leukapheresis people with acute leukemia, not available yet. Basically, substantial reliance on blood products, many situations of lab issues specific to oncology, but however, the general principles of right blood, right patient, right time, and right place supply, avoiding inappropriate transfusions, and using evidence-based medications and sticking with national policy guidelines. So while we aspire to achieve advances clinically, voluntary, non-related blood donation foundation for any possible progress. And we know that we have lots of runs and events and so on for raising funds for people with cancer. And maybe it's time for the various cancer charities to look at blood drives as well. Thanks very much.
Thank you, Dr. Pandoleo. Next on the agenda, we have Dr. Shadi Lagal, who has worked in pediatrics for the last 10 years and has worked as a pediatric registrar for the last 5 years and completed a pediatric training in 2018. She has a strong interest in pediatric hematology. As such, she commenced the Doctor of Medicine program in hematology and blood banking at the University of the West Indies and is currently in the second year of the program. She will share with us an audit of blood product utilization at a neonatal unit at a tertiary hospital. Please welcome Dr. Shadi Lagal.
Good afternoon, everyone. Thank you for the warm welcome. It's my pleasure to be able to present today. So I did an audit earlier this year, and that's the basis of my presentation. It's an audit of blood product use in a neonatal unit at a tertiary hospital. The aim of this audit was to assess current blood transfusion practices at a neonatal unit at a tertiary hospital and compare it to an international standard. So what was done, the necessary permission was sought and obtained, and data was collected over a 2-month period, looking at the patients who would have received blood transfusion. The parameters recorded for the patient's demographics, and most importantly, the patient's postnatal age, the type of transfusion received, and their blood parameters prior to the transfusion. Also, I looked at the type of ventilation people on, with positive pressure ventilation, oxygen, or if they were on air. So the international standard used was the British Committee for Standards in Hematology, their transfusion guidelines for neonates and older children. So this table here looks at what they would have recommended. So in particular, they would have looked at the postnatal age of these infants and the ventilatory status. So the hemoglobin threshold, which should prompt a transfusion, was based on how old the child was and how they were ventilated, how much ventilatory support they required if they needed at all. So as you look at the second column, you will see as they got older, right, the threshold would have dropped. And similarly, if you look at the last column, if the HB threshold would have dropped with postnatal age. Also, the hemoglobin threshold would be lowered if they required less ventilatory support. The threshold suggested by the British Committee for Standards in Hematology. Their recommendation for platelet transfusions would have been is outlined here. They suggest one of less than 25, regardless. If the patient's platelet count is less than 50, they should be bleeding or have a coagulopathy or may be having a neonatal alloimmune thrombocytopenia and had a sibling who was affected with intracranial hemorrhage. And a higher threshold of 100 was suggested if the patient was having major hemorrhage. The indication for FFP, as suggested by the international standard, would have been significant bleeding or prior to invasive procedures with a risk of bleeding and prolonged PTT. So what did I find? There were a total of 115 transfusions over this 2-month period, and most of them were the premature infants who would have received transfusions, representing 84.4%. Thankfully, there were no adverse reactions during this period. And we are looking here now at the ventilated patient who would have received red cell transfusions. So in the first column, I have outlined the patient's postnatal age. The second column is a reminder of what the thresholds were suggested by the BCSH, the standard. The third column looks at what I would have found. So for patients who were within the first 24 hours of life, there was one patient representing 3%, and that patient, their hemoglobin was greater than 12. So according to the BCSH recommendation, they should not have been transfused, however they would, right? So that would have been taken off as inappropriate. Next, we had patients who were 2 days to 7 days old. We had, I had 3 patients in that group, and 3 patients whose HB would have been less than 12, and they were appropriately transfused. However, going on to the next group of patients, those who would have been 8 days to 14 days old. So there were 4 of them whose HB was less than 12, and they were appropriately transfused. However, 5 of them, representing 14%, their hemoglobin count would have been greater than 10, and they were transfused. So according to the guideline, that was inappropriate. On to the patients who were in their 3rd week of life, we had 4 of them whose hemoglobin count was less than 10. They were transfused. That was appropriate. However, 18 of these patients, their hemoglobin count was greater than 10, and they were transfused, and this is deemed as inappropriate. So that represented 50% of the ventilated patients who would have received red cell transfusion. This is a similar table, and this is the patients who were on CPAP or receiving oxygen therapy. And there were a total of 10 patients, and all of them received transfusions, although their hemoglobin count was greater than 8.5, which was the threshold of the BCSH recommended transfusion for the hemoglobin count was less than 8.5. So all 100% of them were inappropriately transfused according to the guidelines. Then I looked here at the patients who may have received red cell transfusion, and there were a total of 7 of them. 1 would have received a transfusion, although their hemoglobin count would have been greater than the suggested threshold, and 6 of them would have received transfusion, although they would have their hemoglobin count would have been higher than the threshold suggested. So looking at the total of all patients who have received red cell transfusion using the international, the green would have represented where we would have done what the standard suggested. The red would have indicated where we would have differed from the standard. So that would have represented 79%. On to platelet transfusion, a similar table. We have in 15% of the cases, their hemoglobin, their platelet count was less than 50, and they were asymptomatic, meaning they weren't bleeding. However, they were transfused. That represented 15%. The green, however, represented where we would have done what the guidelines suggested. So that's 85% we did what was suggested. For FFP use at the neonatal units, there was a total of 29 transfusions. 100% of the time, there was appropriate use of that blood product. So in conclusion, the number of cases where we would have differed from the international standard was 46 out of the 115 transfusions, which represented 40%. However, we were on target for 60%. So what do we have to consider here? We can see that the transfusion done at the neonatal unit exceeded that of what is recommended by the international standard. However, we must consider that this standard was established in a first-world setting where blood would be more readily and more quickly available. We have to consider the uncertainty of how fast we would get blood products here when it's needed. So that could probably prompt the different thresholds that we use locally. We also have to look at the patient burden compared to the staff that we have available here. The patient burden here is quite heavier. And as such, there will be less close monitoring. And we may tend to overtreat, over-transfuse as a result of this. We also have to consider the lack of the poverty of local data on patient outcome using the different thresholds. Right? The threshold we use is the threshold that is suggested by the international standard. We also have to consider that the thresholds that they suggest the international may not be applicable to our local population. So we also have to consider, of course, the many risks associated with blood transfusion. And there are many. We try to mitigate it, however, these risks still do exist. So what would my recommendation? I recommend that local studies be done to determine if the international standard is applicable to our local setting. We should do a case-by-case review of the patients who did not meet the quote-unquote international standard and determine if these transfusions really indicated if it was appropriate or not. We should also have a meeting of hematologists and neonatologists to revisit and to update the local thresholds, right? And with time, this should be re-audited. We should consider lowering the threshold, especially for red cell transfusions, as the greatest discrepancy was seen here in that group compared to the international standard. We should also liaise with the other NICUs locally to see what works for them and how is that impacting patient outcome. So I would have contacted 2 of the other neonatal units, and all 3 units practice something different. And there should be standardization of the local guidelines to be applied to all neonatal units. So thank you very much.
Thank you, Dr. Tobago. Our next presenter is Dr. Cassandra Joseph. She's a graduate of St. George's University. She works at St. Granny Hospital and has been at the hematology unit for the past 5 years. Dr. Joseph has a keen passion for hematology and is in the DF Hematology and Blood Banking Degree Program. And this is her second year. She would like to present to us now blood component use in adults. Please welcome Dr. Joseph.
Good afternoon to everyone. Thank you for that welcome. And I would like to thank you for allowing me to present to you today. I'm going to present one case of a patient that I've grown to know
very intrinsically and come to appreciate how. So just a brief introduction. Transfusion reaction do occur during transfusion, though they are infrequent, and they are defined as any adverse event associated with transfusion of a whole of one of the components. They vary in severity from minor febrile reaction to life-threatening hematologic reaction. Of note, the volume of blood transfused is not relevant, and that the febrile non-hemolytic transfusion reactions which tend to be benign is the most commonly reported. So our case begins with an 83-year-old female who we treat for refractory myelofibrosis. She requires frequent red cell transfusion and supportive therapy. On this occasion, she was admitted for symptoms of anemia, and her symptoms included weakness, fatigue, exertional dyspnea. On clinical examination, she appeared pale and tachycardic. Otherwise, clinically, she was normal apart from splenomegaly. Her CDP parameters include a hemoglobin of 5.3, elevated mean cell volume, and the platelet count of 65, which is normal for her. And the remainder of her parameters were unremarkable. So, based on her clinical symptoms and her CDP hemoglobin concentration, the decision was made to transfuse her 1 part. During the transfusion, within 30 minutes of receiving her transfusion, she developed a fever of 38 degrees Celsius. She also complained of chills and liver. The competent nursing staff that we had, they held the transfusion and informed the doctor who performed clinical examination. We were provided with her vitals, which was 125 over. Her pulse at that time was 78 and her respiratory rate was normal, and she was saturating quite well on the way. She appeared well, asymptomatic, and not in any respiratory distress. Her lungs were cleared on filtration. In particular, there was no sign of breathing. Her cardiovascular examination was within normal limits. The doctor did assess the urine output, which was normal and clear, and repeat vitals were done. Her blood pressure was stable at 112 and 70, but she was febrile at 38 degrees. And again, her saturation was within the normal limits. So once the doctor was able to define that she was not in any absolute distress, we then just treated her with ibuprofen and monitored her. Within 30 minutes of receiving ibuprofen, her symptoms resolved, and the transfusion was then restarted, so at a slower rate after about 45 minutes. The patient was able to complete the transfusion without any incident. And of note, on future transfusion, she did have similar episodes. So, what is our diagnosis? Febrile non-hemolytic transfusion reaction, which is defined as an increase of 1 degree Celsius over 37. The patient at that time will have no other clinical symptoms. We must clear that patients are having an allergic reaction, a hemolytic transfusion reaction, and that they are not hypotensive at the time. It is the most common transfusion reaction we can see, and it's usually caused by the accumulation of cytokine that's in the blood product, in the blood component. So when you look at the patient's blood pressure, make sure the patient is stable, urine output, making good urine, and the patient doesn't have any respiratory symptoms.
managers usually just include and or the transfusion can be started safely and complete without any incidents. For future transfusion, which can consider a local depletion of the blood. Now, I did say that at that time the doctor had the insight to just hold the transfusion, treat the patient, and then restart. This is not something that normally happens. Unfortunately, from my experience, most of the time they need to stop the transfusion and then start the unit. Now, we know blood is an vital, important product. It comes from somebody's body, it is the breath of life. So is that advisable where we have the most common transfusion reaction, fever, non-hemolytic reaction, and most of the time, or a lot of the time, not most of the time, the blood component is discarded. Why does that happen? I believe it's just lack of information, lack of knowledge based on our clinical staff that you can restart the transfusion, what's the real cause, and that the patient can receive the transfusion as a continuous to refuse the transfusion. So in summary, fever and non-hemolytic transfusion reaction is the most common. Our clinical assessment is very, very important. Please do not discard the integrated unit as cost a lot as people think, and it can lead to blood wastage, and we can transfuse the unit. Thank you.
Thank you so much, Dr. Joseph. Now we get to our medical school, UB Medical School presentations. We are going to ask the members of the Fancy Beta investigators, the FBI group members, to come forward. They are going to present to us the burden of beta thalassemia major on the blood banks at a tertiary institution in Trinidad and Tobago. Group members include Jethro Bailey, Josiane Baker, Rosario, Sashim Balkaran, Levita Balkissoon, Sharice Bandu, Ariana Batiste, Mary Claire Balcont, and Miguel Arceo. A small subset of them will be presented. So please welcome them from the Fancy Beta.
Good day, everyone. Thank you, Dr. Charles, for allowing us this opportunity to present our research today. Our research project was done on the disease burden of beta thalassemia major on a blood bank at a tertiary institution in Trinidad and Tobago. So, beta thalassemias, what exactly are they? Is there anyone here who actually was what it is? Can I have a raise of hand? So beta thalassemias are a known group of blood diseases, which are characterized by anomalies in the synthesis of the beta chains of hemoglobin. And they can result in variable phenotypes, which can range from clinically asymptomatic individuals to individuals with severe anemia. So, and this is all because of point mutations in the beta gene. So of the major types, beta thalassemia major is the most severe and life-threatening, and it typically occurs from the age of 6 months of age in the form of severe hemolytic anemia. It affects approximately 0.005% of TNT population. However, carrier rates of data on carrier rates appears, hence the inheritance pattern cannot be mapped and is very unpredictable and difficult to trace within the country. However, skeletal, developmental, and neurological problems are seen in undertransfused patients. So currently, beta thalassemia major patients are dependent on blood transfusion every 2 to 6 weeks, as well as iron chelation therapy for the complications of iron overload. And throughout this study, we actually gained some insight on the effect that this disease has on the blood donation system, as well as the blood donation crisis. So our aim was to determine the effect constant blood transfusion for beta thalassemia major patients has on the blood bank at Eric Williams Medical Sciences Complex. And our objectives were to assess the fraction of blood donated that is allotted to beta thalassemia major patients, as well as to assess the adequacy and management of blood donation at Eric Williams Medical Sciences Complex. The study was a clinical audit of transfusions for beta thalassemia major patients between 2016 and 2021 at Eric Williams Medical Sciences Complex. We utilized transfer analysis as well as logistic regression for our test strategic data, and our study population was beta thalassemia major patients in Trinidad and Tobago. Study sample the patients, beta thalassemia major patients treated at Eric Williams Medical Sciences, which actually turned out to be 11 patients, and our sample calculation was done with a score of 1.04 and confidence of 0.
Pertaining to the data collection process. Data collection process. Two of my colleagues were afforded the privilege of having access to the hematology unit at the Eric Williams Medical Sciences Complex, where we extracted data from the thalassemia major records into a self-made questionnaire. Now, into this process of data collection, it must be noted that we maintain confidentiality, identifying the records by number, by name. So among the demographical data such as age, gender, ethnicity, as well as residential data, other key points were necessary to answer the aim of this objective of the research project, such as the presence of spinal abnormalities, the presence of splenomegaly, as well as if the patient had underwent splenectomy. Now, to assess the adequacy of their treatment, there were key points that needed to be noted, which were the pre-transfusion hemoglobin concentration, as well as the number of units of blood donation and frequency. This will help us to assess the adequacy of the treatment of these patients, whether they were being under-transfused or over-transfused. Pertaining to our findings, based on age and gender, there was no significant correlation in the prevalence of beta thalassemia major in Trinidad and Tobago. However, interestingly, based on ethnicity, 82% of our participants were of East Indian ethnicity, where 18% were of mixed ethnicity. So therefore, it can be inferred that in Trinidad and Tobago, there's an increased prevalence of beta thalassemia major in the East Indian ethnicity. Regarding the comorbidities which were noted, out of our 11 patients, 4 had comorbidities, and of those 4, 2 were endocrine disorders. And this is a manifestation that indeed our patients have been experiencing some sort of iron overload. Now, what was stated before, serum ferritin levels as well were noted to extrapolate or to assess the iron chelation therapy that our patients were receiving, to note if they were on infused. Moving on to the serum ferritin level. The normal serum ferritin level ranges from 13 to 300 micrograms per liter. Now, with our mean, we noticed that our patient experience, our mean for our serum ferritin level was 2,201. Thank you. Sorry about that. So at our serum ferritin level, we noted that our mean was 2,201, which was significantly above the reference range of 13 to 300. So this indicated that although the individuals were being transfused, they were severely under transfused, and also they had high iron overload in their system. So this is a key indication of better produce more transfusions. Additionally, regarding the pre-transfusion hemoglobin concentration, it also was significantly low of 7.16, below the appropriate level of 9 grams per deciliter. This, along with the number of transfusion as well as the frequency, proved that these patients were not being transfused enough, and their hemoglobin, the pre-transfusion hemoglobin concentration was not in the appropriate range. Although their pre-transfusion hemoglobin was severely low, we noted that persons that underwent splenectomy, their transfusion rate were more improved than those that did not undergo splenectomy. All in all, we noted that the population of patients with beta thalassemia, although overall it may seem insignificant, in the total blood donation in Trinidad and Tobago, 1.37% of those blood donations is allocated to the beta thalassemia major patients in Trinidad and Tobago. Okay. So in conclusion, bone marrow transplantation seems to be the only proven cure for beta thalassemia major. However, due to inaccessibility and unavailability of bone marrow donors in Trinidad and Tobago, treating beta thalassemia major patients with regular blood transfusions is the only feasible option for Trinidad and Tobago. Now, according to the Ministry of Health and PAHO, annually, 20,000 units of blood is collected in Trinidad and Tobago. However, according to the World Health Organization, 65,000 units of blood is supposed to be collected for the population of Trinidad and Tobago. This shows just how undersupplied our blood banks really are. So, from the period of 2016 to 2021, 264 units of blood have been allocated to 11 patients annually. Now, is this sustainable or is this adequate? That's the question that we need to answer. And we found from the research that this was indeed sustainable but not adequate enough, because these patients still presented with clinical disorders associated with under-transfusion. So therefore, our treatment really should aim at both sustainability and adequacy. And in order to achieve this, we must improve the knowledge and public awareness of beta thalassemia major, coupled with providing incentives to increase the voluntary, non-remunerated blood donations in Trinidad and Tobago. Now, we found from international research that new treatments and therapies, as well as screening, can assist with this. However, due to our economy, this is not feasible for us. So our main limitation was actually sourcing up-to-date information about our study sample and variables, as well as some other things to note was having a small sample size that prevented any kind of generalization. So what we recommend is making information available to the public about beta thalassemia major, as well as to continue to push the narrative for voluntary, non-remunerated donations. We should also look to cheaper inoculation therapies. That way we can reallocate funds to blood campaigns, blood donation drives, and not focus on expensive inoculation therapies. So with this, as I close, I just want to reiterate the importance of becoming a voluntary, non-remunerated blood donor so that you are able to improve the quality of life of these under transfused beta thalassemia major patients. I'd just like to thank you all for listening. And just remember, donate today, spread the word, and save a life. Thank you.
Thank you very much, Nancy Beasley. Next up, we have the non-remunerated blood pals group members, which include Chelsea Samaru, Jonathan Salamat, Karine Sampson, Matthias Sampa, Sabrina Samuj, Serafina Guzman, Shannon Samaru, and Vandana Samla. And they're going to present for us an investigation of the impact of the COVID-19 pandemic on a known donor group at the University of the West Indies Blood Donor Foundation and a general community group in Trinidad and Tobago. So please welcome the non-remunerated Blood Pals group members to the floor.
Good afternoon, everyone. We are the voluntary non-remunerated blood pals, and our topic is an investigation of the COVID-19 pandemic on voluntary non-remunerated blood donation on a known donor group at the UW Blood Donor Foundation and a general community in Trinidad and Tobago. So what is voluntary non-remunerated blood donation? So this is blood that people donate freely without receiving any payment in return. However, 70% of Trinidad and Tobago's blood transfusion needs are not met. And as a result, most of the donations received are due to family replacement blood donation. Therefore, promoting and shifting towards voluntary non-remunerated blood donation promotes a more sustainable. This way, blood is collected in a safe manner and it's available to anyone who needs it. So our objectives are firstly to describe the knowledge and practices towards voluntary non-remunerated blood donation during the pandemic among the UW Blood Donor Foundation members. Secondly, to describe the knowledge, attitudes, and practices towards voluntary non-remunerated blood donation during the pandemic in a community group. And lastly, to determine the motivators and demotivators of voluntary non-remunerated blood donation during the COVID-19 pandemic. So our study design was that of a descriptive study, and participants were recruited based on an inclusion and exclusion criteria. So the inclusion criteria were persons between the ages of 18 to 65 years old, and the exclusion criteria were persons who were unable to donate due to underlying conditions that they may have. Our data was also collected using self-administered questionnaires that were distributed in a Google form. So they were sent via email to the members of the UW Blood Donor Foundation. And for the persons in the general community group, we collected responses by distributed via Instagram and WhatsApp. And altogether, we were able to collect 244 responses, 68 of which came from the UW Blood Donor Foundation and 176 came from the general community group. So in table 1, table 1 illustrates obtained responses for the awareness and knowledge in this survey. So we see that 97.1% of persons from the UW Blood Donor Foundation were aware of voluntary non-remunerated blood donation, as opposed to 70.5% from the general community group. We also see that the members of the UW Blood donation were also more aware of the knowledge of blood compared to the general community. Figure 1 is a bar chart showing the distribution of participants based on age and sex. And throughout all of the age categories, we see that females participated in
voluntary non-remunerated blood donation during the pandemic. We also see that 47.1% of participants from the Blood Donor Foundation participated during the pandemic, because the most amount of participants that were there. And there was also a large number of persons in 25. So we believe of the medical students that donated during the pandemic, and that's why there was such a large number in that age group. Figure 2 is a bar chart illustrating reasons for donating during the pandemic. So here we see, as expected, the members of the UE Blood Donor Foundation donated more during the pandemic as opposed to persons from the general community group. We see there's 91.84% of them donated during the pandemic. And their reason was also to wanted to help others, and 65.3% of from the Blood Donor Foundation donated for that reason. This table also shows that 7% of persons from the general community group donated based on family replacement blood as opposed to voluntary non-remunerated blood donation. So this shows that there is increased need to promote voluntary non-remunerated blood donation and use.
Okay, so I'll be continuing with our findings. So figure 3 is a bar chart illustrating reasons for not donating during the pandemic. From this chart, we can see that 50% of persons from the UE Blood Donor Foundation did not donate due to fear of contracting COVID-19, while 40% of persons from the general population noted that they did not donate since they were unaware of blood drives being done during the pandemic. Figure 4 is a bar chart illustrating projections to encourage voluntary blood donation. So the most common projection among both groups was raising awareness and education, with 40.1% of persons from the Blood Donor Foundation and 61.36% of persons from the general population projected this treatment. Additionally, it was noted that the use of social media would assist in disseminating information about blood drives. Lastly, approximately 32% of persons from both groups suggested that having alternative accessibility such as mobile units would encourage more persons to voluntarily donate.
So in conclusion, in this study, it was found that the UE Blood Donor Foundation immediately engaged in VNRBT, whilst the general community group mainly participated as family replacement. And in addition, as seen from the data, the fear of contracting COVID-19 and being unaware of blood drives were the major inhibitors to VNRBT during the pandemic among both groups. Additionally, this study further highlighted the blood supply deficit in Trinidad and Tobago, which was worsened due to the COVID-19 pandemic. And therefore, it is imperative that more efforts be made to improve the knowledge, the attitudes, and the practices of voluntary non-remunerated blood donation so that a sustainable blood supply can be achieved. Noting that no strong conclusions can be drawn from either groups, since our calculated sample size was not met as distributing the online questionnaires limited the number of responses that could have been obtained. It is, however, evident that from the findings of the study that the overall improvement in knowledge, advertisements, and accessibility of blood donation sites in Trinidad and Tobago are the key to moving towards VNRBT and ultimately achieving a sustainable blood supply. So therefore, our recommendations and next steps from this study, which was supported by the data presented, would be firstly to improve the citizens of Trinidad and Tobago, their knowledge and awareness of the importance of VNRBT and the shortage of blood supply by involving stakeholders such as the Ministry of Health. Additionally, the dissemination of updated information through every available avenue in order to reach all demographics to promote blood drives and to eliminate the fear and misconceptions associated with VNRBT. Moreover, there should be increased avenues for blood donations and the decentralization of blood donation centers, which has the potential to even reach more donors. And finally, we can have follow-up surveys which can be done to further access the knowledge, attitudes, and practices of vulnerability from both groups after the implementations are done. So in closing, we would just like to express sincere thanks to the UV Blood Donor Foundation and Dr. Nicole for facilitating our questionnaire, and also to all the respondents and to our research supervisor, Dr. Kenneth Charles, for this opportunity.
All righty. Thank you all very much. Can you believe that we are in front of the schedule? So isn't that lovely? So we have time for more questions. So we have 2 questions from the online space. Anyone else who has any questions or comments, and feel free to do so. I think 3 questions, right, from the online space. First 2 are directed to Dr. Shadi Lagal. 1 is directed to Dr. Cassandra Joseph. So please, so the first question came from Dr. Keith Wilson. And his question is, well, first of all, he said, congratulations, excellent audit. Were the causes for transfusion documented in the event that there were other extenuating circumstances that might have prompted transfusion? Which was my question.
Yes, the causes were documented. So, for example, we would have had one case where they were transfused, where the hemoglobin count was greater than 12, the threshold suggested was 12. However, in that case, it was a patient with a massive pulmonary hemorrhage, and well, they were not able to check hemoglobin count prior to transfusion. They would have used blood and blood replacement and assumed that hemoglobin would have dropped a lot. So in that case, they would have been transfused. So yes, it was documented, but it wasn't the focus of the audit.
So there was a column though that you said that it was inappropriate. So was the standard of inappropriateness just the level at which the transfusion was done, or were the clinical situations surrounding transfusion also?
So based on the guidelines, they have a, you have to consider the clinical situation, right? So the appropriateness was based on the HB threshold, according to what I outlined. I used the HB threshold to determine whether something was appropriate or not. However, the guidelines suggest that you have to consider the clinical situation. At a point in time, it's a guide, but not something absolute.
All right, so I guess what's fair enough to mind it may not have been a drastic as before 6%. So you have recommended potentially clinical situations may have modified transfusion. Okay, good. And next up, the US one. This one is from the customer, who also has very good audit. What were the reactions of the clinicians? Did they explain why they were using higher thresholds? Are the clinicians involved in hospital guidelines with the hospital transfusion committee? So let's start with the existence of a transfusion committee. Is there one at that particular tertiary institution?
No, there is none. Can you remind me please?
Yes, I can. Especially since I answered my question. So what were the reactions of the clinicians?
Well, they were accepted, right? They said, Dr. Fox, and they are able to improve their transfusion process. So it was nice to see it put in, figures, so that you see how much they would have differed from the international standard. They said they are not surprised. However, it would have been based on their clinical experience why they would have chosen to transfuse these patients. For example, platelet transfusion. They said Texas was a major cause, a major fear of the unit. It was quite problematic. They were more liberal in giving platelet transfusion. So, I may not have mentioned it. They will follow their own hospital protocol. So they had their protocol and they followed their protocol. However, it varied quite a bit from what the staff we have said. Like there was a part to that question. Did I
So did they explain why they were using higher thresholds? Well, I guess it's sort of touched on that because they had their own protocols and they following those protocols. So I guess those protocols need to be updated, which is what you mentioned. So let's move on. And then anyone in the audience, please feel free if they would like to share anything. All right. So Dr. Joseph, this question is from Dr. Wilson, and it is, are cellular blood components routinely depleted? This would reduce the incidence of febrile non-hemolytic transfusion reactions. So,
no, they are not. It is our goal for this transfusion practices to be used with to decrease
any ideas how much of the blood components are, what percentage are liquid depleted currently?
0.
Dr. Tom, you want to insert yourself?
That we use as sample. I say that before, if we do require lubrication, we do the
No problem.
Time. We have available on request. We seeking to actually make people someone available. And as for the hospital transfusion meetings of which will all become members of the community. That these potential to be brought to them. But if you
the cost of producing these units, or
no, I think it's a question of the country.
okay. Okay, are there any other questions from the audience? Yes. So, Dr. Sharp, as you are walking back up, just to meet what people you have.
Questions from the youth. The patient with the febrile transfusion reaction were any investigation prior to resuming the transfusion.
At that time, no. I did take a blood sample. I did take a sample at that time, and so at that patient, everything was normal, came back normal. But for the future, because she had recurrence, we didn't record it. We just knew how to get a reaction.
Just have one more comment. I think so. I know you mentioned resolution, but uniform. I think depending on the guideline you follow, I think you recommend how to manage. Actually, do recommend not to recommend extreme culture. So it would be interesting and using for what year kind of why.
I have a question from
Yes, Dr. Tobago. So you're mentioning radiation and anemia as a reason for and the very limited evidence that these have seen. I said some of my patients are referred for radiation, and ideally should have concurrent chemo RT. Come back to me and say, well, if their hemoglobin is too low and it's just single agent cisplatin, which in and of itself is not very hemotoxic and it doesn't cause any major declines in hemoglobin generally. So what are your thoughts on that, and how would you have treated it?
It's an incredible demonstration of institutional memory that there's the petition that hemoglobin of 10.0 plus is necessary for any kind of treatment. Hemoglobin of 9.99 requires emergency transfusion, especially the poor chemo and radiation, regardless of whether they intensive curative or palliative, was something I met when I joined there in 2005. Thought that I had completely finished off when I had to graduate from the time. And had researched from people who were in high school at the point when I was in this place. So just the impact. First, we have, as I was indicating with radiation, it was a theoretical concern that since tuber hypoxia could possibly adversely impact radiosensitivity, and transfusion could in theory maybe ameliorate that hypoxia, then there was that reluctance to have people radiated with relatively low hemoglobins. But delaying treatment. So we're talking about radiating with slightly low hemoglobin being an unproven, theoretically possible slight decrease in the effectiveness of treatment, whereas delaying your treatment dramatically reduces the effectiveness. Splitting your radiation course dramatically reduces the effectiveness. You need to pick up again and try to work on the development of the dose. You will not get the same cure rates as the course. And finally, leaving out the concurrent chemo in the curative setting like civic cancer is definitely for the patient at risk. And so with radiation, I want to maintain 8 to 9 plus, and outside the radiation setting, you can maintain the same kind of restricted red cell transfusion approach as with any other medical patients.
So you would give somebody with hemoglobin of 9 concurrent, correct?
Yes.
And even 8.
Yes.
Thank you.
And it's possible to manage anemia concurrently with your cancer treatment rather than abandoning treatment where you start with the anemia and then again.
Thank you very much.
Considering the results of transfusion and why we have to how we started. Where we were spoken about the case where there was a massive pulmonary hemorrhage, and the cases where there would have been dire clinical need to differ from the guidelines were more the exception. So I could count on my hand some cases where there was extenuating circumstance where they should.
Okay, no problem.
That is, so there were guidelines that were for more liberal transfusion. Did they see where those where their guidelines came from? Or what they were based
on? No, that's when I discovered that it was just what they could have adopted. That's what they meant, and would have just continued to revision of it, looking at updated guidelines is needed. So it was just something that I continued from practice before.
One more contribution on track.
I get up to the next one. This is more of a comment and to the symposium. So first of all, my name is Anna Williams from Medical Associates Hospital, Private Hospital, and we are proud to be part of the Symposium of Change. We actually are very, very, very proud to be part of this because as a lab technician, I am a lab technician at Medical Associates, and the chip system is not very ideal at the hospital. And we've called many times our blood bank. So what I would like to say first and foremost is thank you for the blood bank, for the blood supply, for this team right here at North Central. So thank you so much from Medical Associates because we've called many times and you all have always answered and always provided. But at sometimes we wouldn't have blood supply. So we are therefore will be promoting voluntary non-remunerated blood donation. We are MD, and I would love to donate blood at some point in time. I've never, so you will have actually opened my eyes to actually be a blood donor. So I hope to do that in the future. So thank you for that.
Thank you very much for your contribution. Okay, so as we wind down, we are going to call to the stage Dr. Priya Gopi. Dr. Priya Gopi is an honors graduate of the Faculty of Medical Sciences, UWI Singapore. After her graduate studies, she pursued her postgraduate medical training in the United States. This included a 3-year internal medicine residency program at Howard University Hospital, followed by a 3-year hematology and oncology fellowship at the Virginia Commonwealth University Hospital. Upon her return to Trinidad, she assumed a position as hematology lecturer at the University of the West Indies. She currently works as a hematologist-oncologist and is the head of the Department of Hematology and Oncology at Osanga Family Hospital. Please welcome Dr. Priya Gopi. She's going to close us all.
So much the moment. I have the very doing before the panel. Right. So firstly, I'd like to thank all of our audience, participants who are here in person, as well as those who are joining online via the panel. Right. And then, of course, I'd like to thank our speakers, our local experts for today, as well as our international speakers joined us. Professor Roberts, as well as Dr. Wilson. I'd like to thank our UWI students who presented their research and their cases, postgraduates, as well as our undergrads, right? And I'd like to thank our sponsors. They are listed nicely at the back of the program. So thank you for sponsoring our symposium today. And then I'd like to thank the university as well for providing us with to host this event. And they were also recording this event and transmitting it so that most people can participate. Right? And then last but not least, I'd like to thank all my colleagues who made this symposium possible. This is our first symposium, our first national symposium as a hematology society, a hematology and blood transfusion society, and it's a really important topic that was discussed, voluntary non-remunerated blood donation. So I'd like to thank my colleagues, Simone, Carolyn, Dr. Friday, Dr. Capelday, right? Everyone, right? Dr. Leela, so many people who are part of this, and then most of all, Dr. Chow, who is the one who put together this whole team of hematologists. We've never had a society of hematology, and he was the one who made sure that we all came together and made this. So thank you very much.
Thank you all for coming. Thank you all for sharing. Thank you for all our spontaneous guests who were good natured enough to come in and share our education and be inspired to become voluntary, non-remunerated blood donors. All right, thank you again. Please have an excellent Sunday afternoon.